What did you say? Just
అరేంజ్మెంట్ చేస్తున్నాం. చీకట్లో
మన కూడా పెట్టేస్తాం.
ఇక్కడ కప్పబెట్టి
నేను పెట్టేస్తాను. ఆడియో ఉందా? ఆడియో ఉందా?
మైక్రోఫోన్ తీసుకోండి.
మైక్రోఫోన్ ఇద్దామా? దీనిలో వచ్చేసరి
నీకుందా?
లేదు.
నీకు తెస్తా, నీకు పక్కకు సమంత.
Yeah, now Raghu, now Jaya and Raghu. Jaya, hi.
Yes, both are there.
Now it is
taken your
now the lights are actually fine. Yeah.
You have kept your own idea. Lights. You have taken your idea.
Yeah. Mobile will do the job.
Yeah, mobile lights.
Yeah.
ఎందుకు అంటే మనం మాట్లాడిన తర్వాత చాలాసేపటి తర్వాత మళ్ళీ వాళ్ళకి ఇంకెవరు వచ్చినా సాయిపురం ఉన్నాడు. ఇంకెవరు వచ్చారమ్మా?
ఇద్దరు ఉంటే సైంటిఫిక్ కమిటీ లాగా ఉంటుంది.
అవునవును. ఫస్ట్ ఆఫ్ మీరు అడుగుతారా నేను అడుగుతాను? 4:30 స్టార్ట్ అన్న 5 minutes. సాయి
ఇది గోపీనాథ్ అని పంపలే అంట.
హెడ్ ఫోన్స్ అయితే కదా క్లియర్ ఫోన్ చేస్తాను.
ఇప్పుడు రియల్ సైంటిఫిక్ మీటింగ్ అంటే ఇద్దరు పక్కకు పక్కవచ్చు. వెల్కమ్ శివకుమార్.
Sir, thank you, sir. Good evening.
శివకుమార్.
Good evening, sir.
Welcome, Shiva. How are you?
Fine, sir. How are you? Jai Prasad, sir.
బాగున్నాయా గుంటూరులో?
Is it audible, sir?
Yes.
Audible
Okay.
after 2 seconds.
Yes, this correct. 2 seconds పడుతుంది.
ఎందుకంటే ఇది ఇక్కడ లేదు, ఢిల్లీకి పోయి వస్తుంది. రియల్ ఇక్కడ ఉంటుంది రాదు. కాంట్రాక్ట్ చేసుకొని దీని వరకు ఇక్కడ మూలం పెట్టుకుంటే ఢిల్లీకి పోయి గోపినాథ్ మొక్కలే అంట. సచిన్ 2 పాటలు
వాలే సార్ నమస్తే. సార్ నమస్తే. వాలే సార్
నమస్తే.
వాలే సార్.
హలో భూపేష్.
భూపేష్. హలో భూపేష్.
వాలే గారు నమస్కారం
सर. हेलो सर. अजय प्रसाद सर, रघुवीर सर, हेलो सर.
हाय भूपेश.
హలో భూపేష్.
हेलो सर. हेलो सर.
Your audio is
మీరు పెట్టుకోండి. నెక్స్ట్ టాక్ ఏంటంటే మీరు ఆర్గనైజింగ్ టీం నుంచా? ఇక్కడ డాక్టర్ మీరు వెరీ నైస్.
పోయింది కదా?
ఇక్కడ పోయిందండి, ఒకసారి చూడు. యా స్పీడ్ లేనట్టు, అంటే ఎన్ని ప్రోగ్రామ్స్ ఒకేసారి మనం అన్నట్టు ఉండొచ్చు.
This net connection is unstable. It is going and coming. It is going and coming.
This is medicine only, sir. Okay, just log on to
You only do it.
I'll do. Actually, అక్కడే ప్రాబ్లం ఉంది. ఫర్ ఎగ్జాంపుల్
ప్రాబ్లం ఉందా?
వీడియో ఆఫ్. వీడియో ఆఫ్. ఇక్కడ వీళ్ళకి ప్రాబ్లం
ఇంకా మనదే బాగుంది.
ఇప్పుడు షేర్ అనేది చేయడం అంటే చేయలేరు, మనం ఫోన్ చేసి చేయలేకపోతే అంతే కదా. ఉండకుండా రన్ అయిపోతుంది ఇక అంతే కదా, టాక్స్ ఏం లేవు. నెంబర్స్ ఉన్నాయి కదా అందరూ. That is it. We'll start. Who will upload all these talks? Surname Samantha ఒకసారి మాట్లాడదాం.
Hello sir, good evening.
హలో
Hello sir, good evening.
హలో గుడ్ ఈవినింగ్.
Good
Who is
evening.
this?
I am from Grover Audiovisual.
Okay, okay.
When you
Yeah.
will tell, I will start.
Okay. Yeah. Okay. Yeah. Okay. Dr. Swarnendu Samantha?
Yes,
Dr.
President.
Swarnendu.
Yes,
Swarnendu
sir.
Samantha? Yeah, it's a good evening.
Good evening. Good
Yeah,
evening.
it's a good evening.
You can start first talk.
I joined as
Robert,
you,
you can start the
I
first
joined
talk.
as you told me 20 minutes before the timing, so I joined at 4:10 only. No problem.
Yes, we are starting. We are starting now, all faculty. Yes, we are starting. We are
Welcome
starting now, all
to
faculty.
Oasis Con
Welcome to Oasis Con 2020.
Thank you all the faculty for coming.
Thank you all the faculty for coming and giving their
We are going to
valuable
start.
lectures here. We are going to start.
First talk will be
Dr. Armugam's talk.
going to talk on
He's
the
going to talk on the
ACL
ACL reconstruction with the BTB.
AV guys, can you start first lecture?
Start sir?
Yeah, start.
Okay.
Yeah.
Okay.
Armugam first.
I'm Dr. Arumugam. I'm going to talk about craft. I'm from Center of Sports Science, which is a part of Sri Ramchandra University, one of the most advanced state-of-the-art facility for sports science in India. And recently, it's been awarded as the first center of excellence in India for football medicine by Asian Football Confederation. Why BTB graft is preferred, as shown by Sibold recently. It's a ribbon-like structure which is similar to the native ACL, and excellent integration of a bone plug of BTB into the saccade as early as 8 weeks post-surgery. If you see the biomechanics of the graft, the BTB graft ideally matches the native ACL, and more importantly, the outcome. Return to sports, if you see, only BTB graft as early as 4 months of return to sports, whereas the earliest return to sports with the hamstring is 6 months, and quadriceps tendon we have limited data. As shown by this Mayron study review of literature on various factors of the graft, comparing the BTB and the hamstring. BTB graft scores over the hamstring in almost all the important required characteristics of the graft. But then why did the BTB graft become unpopular? The 3 reasons. One is the anterior knee pain and donor side morbidity. And double bundle ACL reconstruction, which became so popular until recently, is not possible with the BTB graft. The traditional transtibial ACL reconstruction used to BTB will result in non-anatomical tunnel placement. You see the anterior knee pain, there is an old type of harvesting the graft, and this is typically what we use, the skin incision, midline incision, and a long one. And no wonder this gives a lot of anterior knee pain. But recently, optimized BTB graft uses only a small incision, oblique incision, thereby reducing the anterior knee pain. As shown in this video, we follow this mobile window technique. Knee position has to constantly change during the harvest. Start with 30 degree of knee flexion and small oblique incision. Then peritoneum is incised on midline. And mobile window is created. First is placed over the tibial tuberosity, and the knee is flexed 90 degree so that the tendons is on tension, so that there is no mismatch on the fibers and bone plug. Once we make the cut on the tendon, use the drill hole to pass the make the hole to pass the graft later on, and always use the motorized saw to harvest the bone plug. Never use any force. Once you do that, then mobile window is placed over the patella with the knee in full extension. Then again use the motorized saw to harvest the bone plug. So with this meticulous technique of attention to detail of surgical technique, you can harvest with a very small incision with a typical tongue. We published this data in recent ISACOS, where we compared 1,250 patients, 600 each in BTP graft and the hamstring, and we showed there's no difference in the anti-knee pain. So anti-knee pain is more related to the graft harvest technique than the problem of the graft itself. Double bundle ACL reconstruction thought to be biomechanically superior, especially with rotator stability. But there's no significant differences in clinical outcome as shown in all these papers. And also one study in 2013 by Scandinavian registry showed high revision rate due to failure of posterolateral bundle. So now the current recommendation is to have a single bundle reconstruction with the tunnels placed at center of footprint, and it gives as good rotational stability as a double bundle reconstruction. In conventional transtibial, it gives a non-satisfactory tunnel position because we used to follow clock position in the transtibial technique, where we used to aim the femoral tunnel either 1 o'clock or 11 o'clock. We all know this is no more followed. We aim for a low tunnel or high position, and the conventional transtibial technique can be optimized to get anatomical position as shown in following slides. So 3 points of optimization for transtibial technique. One is the graft, second is the femoral tunnel position, third is the tibial tunnel entry. The graft as shown, we use the mobile window technique, harvest the tibial tongue, thereby we negate the tibial tunnel length, graft tunnel length mismatch as shown here, and we standardize the bone plug 11 millimeter on the tibia and 10 millimeter for the femur from the patella. It gives more room to rotate the transtibial femoral guide to locate the femoral entry point. The optimization of the femoral tunnel entry point as shown by Stephen Howell, its femoral tunnel is placed at equidistant on the lateral middle or lateral epicondyle. And the tibial tunnel entry point, the transtibial technique is more like a marriage. Once you play the tibial tunnel, nothing much you can do to change the femoral tunnel position. So the entry point as shown by Chhabra is the midway between the tibial tuberosity and the medial tibial border, not close to the tibial tuberosity as we started about 20 years ago. So this gives a good trajectory, thereby you can have an anatomical femoral tunnel placement. This is a video showing, and the microfracture probe through the middle portal, you mark the femoral tunnel entry point, the midpoint on the footprint. Once you make it, the tibial tunnel is created, is the transtibial jig, and serially tunnel is reamed to 11 millimeter of width. Once you do that, you pass the transtibial femoral guide with a 7 millimeter offset, and the way you rotate the guide to rotate inferiorly and downwards, and you make the same point which is made through the middle portal, and you use the 10 millimeter reamer to ream the femoral tunnel, and you can see how the femoral tunnel is nicely placed in the entire footprint of the femur, and this is a way going to the middle portal. The graft is passed and the cancellous bone anteriorly, and then interference screw is used, and you have to make to knee to 120 degree of knee flexion to bring the screw and access to the graft, and this is at the end. Tibia also fixed similarly. You can see the entire tibial tunnel is filled with bone graft. This is a view from the middle portal.
25 साल पहले जैसे गया तो बीटीबी उसी तरह वापस आया हूँ. बीटीबी डा.
So in conclusion, BTP is gaining its popularity. Donor site morbidity can be avoided with a careful surgical technique. Conventional transferable technique can be optimized to achieve anatomic tunnels with the BTP graft, and the ribbon-like BTP mimic the native ACL. Thank you for your patient hearing.
Welcome, Dr. Roshanwade.
Yeah. And please continue the next talk. Please continue the next talk. Yeah.
Dr. I.K. Subramanian. I'm going to talk about hamstring ACL reconstruction. This talk essentially involves three essential topics. One, I'm going to talk, there are issues with BTB, and that is why I chose hamstrings. Hamstring is also a gold standard. And then I highlight what are the things which we can do only with soft tissue grafts and not with a BTB. Talking about BTB graft, I was a BTB user till 2003, and it is supposed to be a gold standard. But then there are many issues with this graft which changed my mind. There were technical issues with the graft. The graft had fixed graft dimensions in form of length and width, and these causes technical issues. I had problems in thin patients where there was a limited area of middle one-third of graft to be harvested. More calculations were required while I was operating the patients using this BTB graft. Sometimes this graft would be long and the plug would be hanging out. Sometimes it was short and there was a problem because bone would be jutting inside the joint. There were issues where I could not use a BTB graft. A lot of my patients had patellar surface irregularities in form of patellar chondromalacia, patellar tendinitis, and they had pain after this kind of surgery. There were some patients who had patellar alta or patella infera, where there was difficulty in harvesting the graft and the graft length was also short. And then we had adolescent ACL injuries where BTB graft could not be used. There are some complications. We also had one where there was a fracture of patella. And I think these problems, issues, and complications changed my mind to another graft option, that is the hamstring. Some of my patients also had issues. This tender scar in the front of their knee caused them problem. There was difficulty of them while doing kneeling, especially sitting on the floor and doing prayers. And some of these patients who were weak on rehabilitation had fixed flexion deformities. So I changed my graft to hamstring grafts. Now hamstring had an advantage. There was a minimal anterior knee pain. There was no fixed flexion deformity. It was useful also in presence of patellar issues, and these issues are commonly seen in ACL deficient knees, and no fractures were there because it cannot fracture. These grafts are good vis-a-vis stiffness. As compared to BTB, a double-stranded STG graft has got a much better stiffness as compared to a BTB graft. Their load capacity also is excellent, and their maximum load capacity is much better than a BTB graft. So these grafts are durable, they are hard, stiff, and comparison to the normal native ACL. Issues with those who start doing hamstring ACL grafts are inadequate graft, and to overcome these, especially our Indian population where graft might be inadequate, in addition to SEMITI, I also started using Gracilis, and this gave me more graft volume. Thin grafts can easily be adjusted when we use hamstrings. We can either 4-tail them, 6-tail them, 8-tail them. And this kind of modularity does help us in restoring the graft diameter and length as much as we need. I customize all my patients. I do an arthroscopy. I look at the footprint. There are patients where footprint is small, but then there are patients where footprint are large. And I try to restore and fill the footprint as much as possible. And this kind of filling the footprint, customization of the graft for each and every patient is easily done with the hamstring, depending upon their either quadruple, 6-tail, or even 8-tail the graft, so as to get a good fill, at least 80% fill of the footprint. This helps in making the graft much more durable and more patient friendly. There are other things which semitendinosus graft can do where BTB does not do. We have started seeing a lot of partial ACL tears. That's a video showing an anteromedial bundle tear, and that's an isolated AMTL. You do have a PL which is intact. In such patients, it is always a good idea to isolatedly do an AM reconstruction and leave the PL because PL is normal. And these kind of partial ACL reconstructions can easily be done by a hamstring graft. In addition, that's a patient with an isolated PL tear, so you can just do an isolated PL reconstruction. Again, soft tissue grafts do help in these ways. We have seen a lot of patients with acute ACL tears. These patients often have ACL avulsions from the femoral side and they need ACL repair. If you're not happy with the graft quality, you can do, in addition to an ACL repair, a hamstring augmentation and protect it with an internal brace. So again, that's something which is something new. You can do an ACL repair in addition to an augmentation with a small soft tissue graft and internal brace set. This gives proprioception, this enhances healing, and these joints do well in a long-term follow. Again, in a high-grade pivoting sports, patients who are 6 feet plus tall with a massive pivot shift, I often do a double bundle ACL reconstruction. And again, soft tissue grafts only can do a double bundle ACL reconstruction. Then there are marketing advantages for some who wants to differentiate themselves in market. You can do an all inside ACL reconstruction. There are advantages with this technique, but it also adds to your marketing value while you are doing ACL surgery. In an adolescent, you can do a physical sparing techniques, which is giving promising results with a soft tissue graft. And also you can do a transphysial techniques because soft tissue grafts do not interfere with the bone growth, and these also gives good results. There are some issues with incorporation of graft and stretch out, which needs to be addressed, and also in contact sports, which needs to be addressed. However, as I do more and more ACL reconstruction using hamstring graft, I realize this is a versatile graft. It's a strong graft. It is friendly both to the surgeon and to the patient. It has got numerous advantages and it is adaptable with the new techniques of double bundle ACL reconstruction, ACL augmentation, ACL repair, and single bundle ACL reconstruction. So this has become a graft of my choice and I use this in almost all my patients. Thank you very much for inviting me for this wonderful symposium. Thank you.
Yeah.
Thanks, IPS. Now I request Dr. Chirag to speak on primary ACL repair.
Hello, everybody.
Chirag,
I would be speaking on ACL primary repairs. ACL surgeries have got a lot of different opinions, a lot of confronting results. The trend nowadays is more towards anatomical and more biological techniques of ACL surgeries. Let's look into a case scenario. 28-year-old active male having came to us with a low-grade twisting injury of the knee, 6 days old. He had got pain, instability, minimal swelling of the knee joint. Now, we examined him and this was his clinical finding. He had grade 2 or grade 3 effusion. Lachman test was positive, grade 3 Lachman test, which was positive. And when we went ahead and did an MRI, we saw that the ACL fibers was intact in the tibial attachment. The mid substance was intact, but there was a proximal attachment tear. It's more like a proximal tibial avulsion. Now, it would be disheartening for us to pull out the entire ACL ligament and reconstruct. What are the treatment options for this patient? Either a more biological repair, augmentation, or a remnant preserving ACL reconstruction. A less biological and a more trending option is go ahead, pull down the ACL fibers and do a straightforward ACL reconstruction. And now a primary ACL repair. It's always been an ongoing debate since many years, and we still haven't found a conclusion or a final verdict regarding do we do an ACL reconstruction or don't we do that. Now, ACL repair started as early as in the early 80s by Mayo Robson. the preferred technique, it was a preferred technique earlier to that in about 30s and 1960s. It was a gold standard treatment for ACL tears. It had good short-term results, but then the mid-term results were not great. There was high re-injury rate. The incidence of pain, stiffness, and instability were high, and this was attributed more likely because of the large arthrotomy scars, post-operative cast immobilization, hence the patient landing up with the knee stiffness, and so on and so forth. Now, why ACL repairs failed in the past? If we also look into the literature by Sherman in 1991, he had good, or what we would say, moderate results with his primary ACL repairs. And one of the reasons why these ACL repairs failed was inappropriate patient selection. In recent times, there have been some midterm results with excellent results in the literature, and this is attributed to patient selection and more appropriate surgical techniques. Now, patient selection is very important. Patient selection, a good surgical technique, augmentation with internal brace or graft, and biology in terms of microfracture or any other augmentation techniques forms the key for the better surgical outcome. How do I do an ACL repair? Now, the same case scenario which we saw some time back, young adult with a proximal attachment tear, here viewing through a atrolateral portal and working through atromedial portal, we see here that it's a proximal attachment avulsion tear. The first thing what we do in such scenarios is go ahead and take a radiofrequency ablator and burr out all the frayed fibers to define the ACL stump much more clearly. As you see here, this is a Sherman type 1 tear. It's a proximal attachment avulsion tear, and the rest of the fibers being intact. One would then go ahead, take the radiofrequency ablator and clear out the the lateral femoral condyle medial wall. This would give us an appropriate picture of where one would like to attach the repaired ACL. Also, this gives us the liberty to do a little bit of a notchplasty. One would go ahead, use a radiofrequency ablator. Furthermore, one could take a scoop and then scoop out the femoral condyle. This serves two purposes. One is a notchplasty. Second is to enhance the healing potential with the bleeding of the undersurface of the bone. One would then take a shoulder suture shuttling device like a first pass device and load non-absorbable fiber wire of either a braided or a colored suture material, viewing through the lateral portal and working through the anteromedial portal. One would either take a running sutures or a single cinching sutures. I usually prefer taking a running sutures, and these sutures are taken through the anteromedial bundle. Once I've taken these running sutures through it could be either a running suture or a self-locking suture one could take. Once we have taken this suture to the anteromedial bundle, I would then shift my viewing portal into the anteromedial portal, use the anterolateral portal as a working portal, and use another color of a non-absorbing suture material, and take my bites in a similar fashion to the posterolateral bundle. Hence, we have the anteromedial bundle, which is sutured in the running suture material fashion, and similarly, posterolateral bundle, which is also held together by another suture material. Hence, we have two sutures which hold the two bundles of the ACL separately. You would then make a pilot hole in the lateral femoral condyle with the desired spot where we would like our femoral insertion of the ACL to be, and then load the suture materials into the swivel lock or the push lock anchor, and then insert this anchor with adequate tension with the knee in about 90 degrees of knee flexion. It's very important that we do not over-tension the graft. At the same time, the integrity of the graft and the adequate graft tensioning is also very important, so that we have a normal anatomy which is restored. I would err more towards the anteromedial bundle because this is more of a functional bundle of the ACL. And once you have done with that, we now see that the distal attachment and the proximal attachment of the ACL fibers are in continuity, and this would hence restore the normal anatomy of the ACL, of the repaired ACL. When in doubt, if you are not very confident about the repair, if it's a young athlete who is much more active and a quicker return to sports is what is desired, one could always go ahead and augment this repair with either an fiber tape, or else one would use a two-strand cemetery graft to augment this kind of a repair. I usually augment my repairs with the two-strand hamstring graft. That's either a cemetery or the gracilis, depending on what the patient's profile is, what the BMI of the patient is, and what activity demand the patient would like to resume. Once we have drilled our tunnels in the femoral and the tibial side, one would use a suspensory device for the femoral side, and then aperture fixation in the tibial side. And like how we reconstruct an ACL, one would augment this primary ACL repair with a two-strand cemetery graft. It's very important that we do not overstuff our intercondylar notch. If we do so, one would be left with the FFD or an extension lag. Hence, it's very important that we go ahead intraoperatively, do a full extension, and see if there's any sort of a notching. If there's any sort of notching of these of the augmented fibers, one would debulk the fibers or do an additional notch plastic. Now, what are the key for the better surgical outcomes? Appropriate patient selection, a good surgical technique, augmentation as I suggested, and to enhance the biology. All these parameters do play a role in a quicker recovery and better results of the primary ACL repairs. In terms of patient selection, the type of tear is very important. Duration since the injury, age of the patient, BMI of the patient, activity demand, and of course the associated injuries do play a role in the patient recovery. Tear location, we all know Sherman has classified the ACL tears into 4 types of tear patterns. Type 1 and type 2 tears, which are the proximal attachment avulsions and the proximal attachment stump tears, are the most appropriate tears to be repaired, and these are the ones which would have a high success rate as compared to the mid-substance tear or the distal attachment tears, which may not have a desired result. The patient selection, duration of injury. Now, duration of injury is subjective. It could be repaired as late as 3 months, but we would usually prefer to repair the ACL within 3 weeks to 6 weeks of the injury time. Age of the patient and BMI does play a role. Younger the patient, better the result. Lower the BMI, better the result. Activity demand of the patient is also very important, and we need to keep into account: is the patient a high level pivoting athlete or is he involved in any form of linear sports? Associated injuries, if there are too many associated injuries, one wouldn't go ahead and do an ACL repair, rather do an ACL reconstruction. In augmentation techniques, either an internal brace or a graft, I usually prefer using natural biology, that's a cemetery graft. How do we enhance the biology? The best technique to enhance the biology is by local microfracture. One would go ahead, take a small microfracturing owl and do multiple microfracture in the femoral condyle to enhance the biology and for a quicker healing. Why would I do an ACL repair? It's less invasive, avoids graft donor site morbidity, retains the normal anatomy, collagen orientation, and bundles, especially the footprints, and hence restoring the biomechanics. Possibly retains proprioceptive functions, early rehab and return to sports. Of course, if this fails, there's always a bailout with the ACL reconstruction, hence we are not burning any bridges. It allows partial sparing option in pediatric patients. Indications of an primary ACL repair: recent injury, proximal attachment tears, both bundles intact, continuity of the fibers from tibia to femur if it's intact, and one rare indication or an extended indications is lambda healing of the ACL, where the ACL fibers from the proximal attachment, which is torn from the notch, torn from the insertion, would go ahead and get attached to the roof or the notch or the PCL. And these kind of tears are called the lambda healed tears, and these may be an extended indication for a primary ACL repair. Rehabilitation program needs to be a tailored approach depending on the patient's activity demand. We usually follow a MAC's rehab program, where in the first week we would go ahead with a range of movement from 0 to 100 degrees, quadricep setting exercises, straight leg raises. 3 to 8 weeks continue the strengthening, 8 weeks return to running, and about 12 weeks time one would start his sport specific training. Key to success of an ACL, primary ACL repair: proper patient selection, all arthroscopic technique, appropriate suture control of the torn ACL fibers, stable opposition to the bleeding bone surface at the native attachment site. Thank you.
Yeah, unmute, sir. Chirag, can you unmute?
Yeah, sir. Unmuted.
Yeah, Chirag, as we know that ACL repair results are better in middle age than children.
Yes, sir.
You said that you use this repair in facial sparing. So how do you modify it? So you do repair in children also?
Yes, sir. I mean, one of the indications is a pediatric age group when there is a Sherman type 1 or type 2 tears,
Okay.
especially the type 1 tears, because you do not really need to use the facial sparing technique here because you're using just a push lock or swivel lock anchor. Hence, automatically it becomes a facial sparing. And also another key here is you're not burning any bridges. You're just giving it a chance for the natural biology to heal. If it heals well and good, if not, wait up till the child is facially grown and then do a primary ACL repair, reconstruction.
So in your experience, it is the ideal age for the repair. In general, I'm speaking.
Yeah, there is in the literature, there's no ideal age which is mentioned. Younger age group are the best candidates.
Thanks, sir.
Are we allowed to ask question or we have separate session?
Yeah, you can ask question.
Yeah. Chirag, that was a wonderful presentation for ACL repair. One question which was always been thought of and always discussed was regarding the ACL healing and the pattern of ACL repair which need to be done, because you are shown the classification type 1, type 2, type 3,
yes,
where you will be doing the ACL repair, and type 4 you will be doing ACL reconstruction. Am I right, Chirag?
Sir, type 1 and type 2 are the ideal one. Type 3
Ideal one. Okay. So my question is, bone to bone healing is possible only in type 1, that is the avulsion.
Yes.
The soft tissue to soft tissue healing,
yes,
which is very difficult to achieve amongst the hello.
Yeah. Yeah.
Soft tissue to soft tissue healing, when you have the proximal tear, where do you intend to heal your ACL remnant? Is it at the soft tissue or is it inside the tummy? Because the healing pattern will decide, because if it has been a soft tissue to soft tissue healing, the synovial fluid will always bathe of the fibroblastic activity and you will have a non-healing of the ACL. So can you enlighten on that fact?
So we always augment with the two-strand semitic graft. When in doubt,
so you always do augmentation ACL reconstruction.
yeah. Type 1 you can leave it. Type 2 is always
I think there is a lot of background noise. Can somebody hello?
Yeah.
Yes, Chirag. Yes, Chirag.
Okay. So the type 2 is always augmented with the hamstring graft.
Okay. Thank you, Chirag.
Can I ask a question, Ravi sir?
Okay, Sunil.
Chirag, very nicely demonstrated. I just wanted to ask you two things. Number one, when the ACL is torn, the ligament stretches as well. So how do you compensate for the stretch in the ligament? That is number one. And number two is when you augment, then the tunnel for your graft augment that you pulled, they become non-anatomical. Does it affect the viability of that augment?
Yeah, sir, very valid question. First thing is when you are repairing, automatically you are shortening the ligament. You are shortening the ligament, you are repairing it. And if you see my surgical technique, I have repaired.
There is a lot of background noise. Raghuveer, Jayaprasad, control the
It
background.
is coming from Delhi.
It's coming from?
It is coming from Delhi. We have
IPS.
that. No, what I'm saying is the main conference is coming through the Delhi people. Yes, Delhi office.
So when you are
It's not from here.
Yeah.
When you are repairing, automatically you are shortening the ligament. When you see my surgical technique, I have repaired it at the spot of the anteromedial bundle. So my augmentation will be at the PL bundle. Now your repair is always like conical. So you have a single spot of attachment there that is erring more towards the AM bundle, and the augmentation is more towards the PL bundle.
Thank you.
Okay. Thanks, Chirag. Since Arumugam has joined, Arumugam, can you unmute? I have a question for you.
Yes, Jaiprasad.
Arumugam very well demonstrated patellar tendon.
Thank you.
Suppose if you do these cases in very lax, high grade laxity, you would combine this patellar tendon with extra articular ALL, or you do only patellar tendon?
Now, my indication for extra articular tenodesis are very limited, Raghuveer, when it is a gross pivot shift or a revision ACL. The primary ACL rarely end up in doing extra articular tenodesis, especially when you use a BTB graft. I don't want to do that.
So if you don't combine PTB with extra articular?
Yeah, actually, we get good stability with the BTB. There's no need to do tenodesis.
Even in athletes, Armugam, Dr. Armugam, even athletes, high-level athletes who want to have pivoting activities.
Yeah, I don't do
as a
unless,
primary.
with the BTB is good enough for that.
Okay, thanks, Arumugam.
Thank you.
Aru, can I ask you a question, Aru?
Hi, Roshan. Yes, always.
Hi. How are you? It was a nice presentation. We enjoyed your videos as well. I have a question related to your BTB selection of the patient.
Yes.
How do you decide, especially the young athlete, non-contact sports? Will you consider them for BTB or hamstring? And what about the high-level contact sports, especially football or rugby? Rugby we don't play, maybe kabaddi or any other high-level contact sport. Always do BTB, or you have a selection bias during the kind of
very valid
sports?
question. Very valid question, Roshan. I have kind of any active high-level athlete, whether contact or not contact. I am biased towards BTB. Even female patients, I go for BTB, and so when high-level athlete, high demanding athlete, either non-contact or contact, I go for a BTB graft.
Okay, thanks, Arumugam and Roshan.
Thank you.
We'll go for
Next talk by Dr. Gopinathan, ACL avulsion in adults.
Hello?
Yeah, go ahead. Yeah.
I'm not able to share the screen. Hello? Can you hear me?
Yeah, we can hear you.
But my presentation is not running.
Yes, sir. We are hear you.
One second. One second.
Can I share my screen?
Sir, share your screen.
Can I share my screen?
Okay, what you do is you log out of your Zoom.
Are you video nahi?
I think it has got stalled. So what you need to do is log out of Zoom and reconnect.
You can go for next presentation, then we'll settle.
Now I request Dr. Subair Khan, lecturer, PCL avulsion in adults. AV guys, we'll go for the next talk. Dr. Subair Khan, PCL avulsion in adults.
Hello everyone. I would like to thank Dr. Jaiprakash and the organizing team of the OHSTAN 2020 for inviting me to talk about PCL avulsion fixation in adults. PCL avulsion fixation is, though not a very common injury, it amounts to around 44% of all the traumatic lesions of the knee. Whereas PCL avulsion is, compared to ruptures, is 1 in 5 is very common. Most of the time they are undiagnosed. When it comes to treatment, always the undisplaced fractures can be treated conservatively, whereas displaced fractures need a definitive surgical fixation. When it comes to surgical fixation, we have two options. One is an open arthroscopic options. In open, the main factor is the approach. Burks and Schaeffer in 1990 have established a standard approach to assess the posterior PCL avulsion fragment and fixation method without injuring the neurovascular bundle. Following which, there have been many articles and approaches which have been described by various authors, which are safe to approach it. By open method, the main thing is screw fixation. Only problem with that is can be a possibility of neurovascular injury, a prolonged hospital stay, as well as the positioning of the patient in prone position was a difficulty. But they can achieve a stable fixation because the screw can have a very stable fixation with the help of lag screws. 1 or 2 screws are used to fix it. And there have been a lot of literatures which has been supporting that. When it comes to open fixation, there are many challenges, especially the positioning of the patient in prone, neurovascular bundle injury possibility, especially visualization of the fragment. And if it is comminuted again, it is difficult to fix it. Associated injuries like meniscal tears cannot be addressed very well in case of open method. You need to do an arthroscopy and you have to do open and circular 2 procedure. And of course, the recovery and rehabilitation can be delayed. When it comes to arthroscopic, there are multiple options. The first might be the screw. The second is the anchor fixation. Third, again, suture fixation, which has been well established, and there have been a lot of literature supporting that. And we have established a new technique where we use button and sutures to it. We're going to discuss about it in detail today. So in arthroscopic fixation, established 96 to 98% results in various authors where we use antiquated screws to fix it by arthroscopic method. Another method is the use of the anchors. So various anchors are used to fix the bone fragments. Recently, they have given very good results. The only problem is sometimes they can have a synovitis. And of course, suture fixation has proven to have very good results when compared to even screws. And it is very easy, like what we do for the ACLs. And there have been multiple studies supporting the fixation with the help of the sutures. And there is a comparison study also between the screws, and there was no difference between screw as well as the suture fixation. In hybrid technique, there are 2 main factors. One is the transeptal portal. The second is the suture and the button, the implant, which is used to fix it. And this transeptal portal was described by J. in 2000, and we've been using it regularly for all the posterior joint work. And the key factor is the ABS button, 2 ABS button with the no button tight rope, which is used to fix the PCL avulsion fragment along with the fiber wire. All patients undergoes an X-ray, plain X-ray, to see AP and lateral views about the bone fragment. And of course, MRI, we measure the size of the bone fragment. Based on the size of the bone fragment, we decide about the fixation device. After anesthesia, we keep the 90 degrees and look for the posterior drawer and posterior lockman. I'll explain. The first is establishment of the posterior-medial portal, where the needle is passed through the posterior-medial compartment and established in the posterior-medial portal. So after establishing, switching stick is passed from the posterior-medial portal. Now through the PL compartment, we visualize the posterolateral compartment and the needle is passed. You can see the posterior capsule well above and very close to the femoral contact so that you can avoid the neurovascular injuries here. Then we pass the artery and expand the capsule. Then again, switching stick is passed into it. We keep 2 switching sticks in position. Now the shaver is come from the anterolateral portal into the posterior-medial compartment. Now this is the septum, which is shaved with the help of the shaver. And during this, the switching stick from the PL is pushing the septum, which helps in removing the septum. Now the shaver is switched to the other end and the soft tissue is cleared and the septum is very visualized. You can see the condyle. Now the bone fragment is well visualized. All the soft tissues attachment along with it is removed so that it doesn't come in the way while fixing it. It might lead to delayed fixation or non-union. Once this is done, we assess the bone fragment with the help of the suturing stick, and you can see that very well. The bone is well visualized with the PCL stump. Once this is done, the sutures are passed between the PCL and the ACL into the posterior compartment, and one limb of the suture is pulled from the PCL and into the posterior-medial portal, Another limb also is pulled around the PCL. Now we make a multiple half. Everyone, I would like to thank Dr. Jayaprakash and the organizing team of the OSS Fund 2020 for.
Every guys, you have to complete this Dr. Subekhan's talk. Then you can go for Gopinath's talk. Dr. Subekhan's talk is not yet over.
Today I'm going to present the all arthroscopic technique, how we do the PCL reconstruction. Okay. So whenever we start doing the PCL, the clinical examination is mandatory. Okay.
Hello, hear me guys?
So you must do all the necessary investigations like your
Do
X-ray.
you stop this one?
Yes, sir.
Yeah, please continue Subair Khan's talk. It's not yet over. Please continue Subair Khan's talk.
1 minute, sir. Super.
టాక్ అయిన తర్వాత మధ్యలో బ్రేక్ చేసి ఇంకో టాక్ కంటిన్యూ చేస్తాం. టాక్ కాక ముందు ఇంకో టాక్ కంటిన్యూ చేస్తాం.
Yeah, okay, right.
Yeah.
I would like to.
No, you are starting from initial onwards. You
Start after.
Sorry.
Start after 5 minutes. Yeah, now.
Okay, sir.
Yeah, from here onwards you can go ahead.
Okay.
Well visualized with the PCL stump. Once this is done, the switches are passed between the PCL and the ACL into the posterior compartment, and one limb of the suture is pulled from the PCL and into the postomedial portal. Another limb also is pulled around the PCL. Now we make a multiple.
What happened? Any problem with the video? Hello?
I think problem with the video.
So go ahead with the next talk, Dr. Gopinathan's.
Okay, sir.
Yeah. Hello, Dr. Gopinathan? Hello?
Not.
Hello? Gopinathan, please come on live. Dr. Gopinathan.
I think he's not hearing.
Yeah.
Hello. I can't hear Gopi. Is it Gopi's voice or somebody else is talking? Japa
Dr. Gopinathan.
Unmute yourself.
Unmute. Gopinathan is there? Yeah. Yeah, Gopinathan. Dr. Gopinathan, your video is running. Please,
you talk.
Please go ahead.
You unmute. You unmute himself. You can talk.
Should I
No,
play
no,
again?
your audio is not coming. Your video is getting.
Should I play again?
Yeah. Okay. Yes. Okay, right. Hello, AV guys. Hello, AV guys.
Yes.
Yeah, please allow him to share the screen. He's not able to share the screen. You are playing video, his video.
Yeah,
Take
I
out
need
this
to use it.
video and allow him to come.
Okay.
Yeah.
Now we play next video.
No, his video. Gopinathan, Dr. Gopinathan video.
Again play.
No. You allow him. He is ready to share his screen. So you take out this video and he is going to share his screen. The entire thing.
I allowed already.
Okay.
His video is not coming, sir.
Yeah, we are able to see the video, but the audio is not coming.
No, I think he's not on video call. Please tell him to switch on camera.
And again, reshare. Yeah.
Who is talking at background? Is it Gopinath? Gopinathan is speaking in background?
No, not yet.
Not Gopinathan.
Whose voice is this?
Another hall.
Is it?
Next hall.
Oh, so this is not arthroscopy discussion?
No, entire thing like this. It
We
is
have a
arthroplasty, spine.
8 sessions are going on now.
Yeah, it's like this. Okay. So many people are here.
So please talk to Mr. Gopinathan and tell him to join again.
Yeah. No, otherwise, one thing you can do is you can go ahead with the Swan and the Samantha.
Okay,
Okay,
sir.
we'll have him later.
Okay, sir.
Yeah, please go ahead.
Hello.
Meanwhile, I will speak with him.
Hello.
Yeah.
Hello.
Gopinathan is here, sir. Gopinathan is here.
Yeah, Gopinathan.
Gopinathan, can you share?
Yeah, but somebody is already sharing the screen. So
No,
I'm
you
not
switch off. Every guys, can you switch off your screen?
Okay, sir.
If you switch off only, he can share it.
AV guys.
Yes,
Hello.
Yes, sir. I'm doing.
Please unshare your screen so that he will share his screen.
Yes, sir. Okay, sir.
Please be alert, Baba.
First of all, let me thank the organizers, especially Dr. Jayaprakash Preda, for inviting me to present this topic in front of this august audience. Can you hear me?
Yes.
My presentation is on ACL avulsion. As we all know, it is a high velocity injury, and usually it is seen in road traffic accidents, and associated injuries are always a problem, like tibial plateau fractures. To understand about this problem, we need to have a good classification, and this is a good classification. And in this short presentation, I will be highlighting more on surgical technique rather than review of literature. So the classification we usually use is Mayer and McKeith's classification. The type 1 is an undisplaced fracture of the tibial spine. Type 2 is a partially displaced fracture with the posterior aspect which is intact, and type 3 is fully displaced. Type 3 A is ACL is only avulsed with a piece of bone, and type B is a full tibial intercondylar eminence is fractured, and type 4 is comminuted. So this is a type 1, that is a type 2, and type 3 A and B, and type 4. So these are the types based on which we decide the treatment. So X-rays are always a must, and most of the time the diagnosis can be made with X-rays, but always it is important to have a CT scan to know about the complete fracture of the tibial intercondylar area, and MRI helps us to identify the meniscus, the collaterals, PCL, and other associated injuries. So this problem really needs a detailed evaluation for you to treat. The operative techniques we usually use are the pull-through sutures, which is a gold standard. It's an all arthroscopic technique. It is easy, predictable results, and however, it cannot be used for tibial plateau fractures and acute fractures where there is a communication between the metaphysis of the tibia and a comminuted fracture of the intercondylar area. It always allows anatomical reduction, less chance for adhesions and arthropfibrosis, allows removal of the clots and bone fragments, and also it helps in dealing with the intermeniscal ligament and also dealing with the entrapped lateral meniscus. Operative treatment, type 2, type 3, and type 4 really needs surgical intervention. Type 1 is usually managed conservatively, but there is always a controversy whether type 1 will also get dislodged after some time. Arthroscopy is the gold standard, as I mentioned, and the indications for surgery, as I already mentioned, these type 4, type 1 is debatable. And meniscal entrapment is an issue which you have to deal with. Displaced malunion and loss of extension are the problems which has to be looked for. Instability, less mobility for arthroscopic technique, and screw or suture fixation has got its own disadvantages. Screws may lead to iatrogenic combination of the fragment displacement. It needs a hardware removal. So most of the time, pull sutures are the technique which is usually practiced. First of all, we do a diagnostic arthroscopy, and the standard arthroscopy technique is used, and we need number 5 ethibond passed to the posterior aspect of the ACL close to the fragment, and the suture lasso is useful for this purpose, which is passed through the of the PCL in the posterior aspect. Now we make 2 drill holes on either side, middle and lateral side of the fragment, and the 2 drill holes are made 2.7 mm drill bit, and using an ACL guide, ACL jig exiting through the cortex, medial cortex of the tibia, as you do for the ACL reconstruction. Pass the ethibond through the tunnels, repeat the same on the lateral side. Instead of lasso, you can use a thin wire loop also. This is a short video. So first we do a standard arthroscopy, identify the fragment and delineate the area. And most of the time the defect is smaller and the fragment is bigger. That is what we find usually. Look for the entrapment of the lateral meniscus and see whether intermeniscal ligament is preventing the reduction. So sometimes you'll have to cut the meniscal ligament. Now with a hook, you try a temporary reduction, and this reduction can be maintained by a K-wire, can be removed later on. First you use a lasso. This is a shoulder instrument. Then we pass the ethibond through the substance of the ACL on the posterior aspect, and the first suture passer. And once you have a good anchor of the suture in the substance of the ACL, then it is made to the ethibond. So here retinol wire use, you can use a steel wire also. So this is a shoulder instrument. If you have a good shoulder instrumentation near set, then it is easy to deal of problems in the knee arthroscopy as well. So this is a shoulder instrument we are using. Retinol wire in a shoulder is used here to pass the bond, and you repeat on two sides the same technique so that you have a good hold. As a 2.7 drill bit through which you pass the first and second drill holes, and this has to come out on medial and lateral side of the bony fragment of the avulsed ACL fragment. So this technique is useful in pulling the sutures. Now the sutures are pulled through the medial cortex as you do in ACL reconstruction. And once you pull both sutures on either sides, both sutures will come out and it will fix the fragment in place. Sometimes it may be difficult to put this big fragment into the short defect, but still we will be able to do it with some meniscus into the curve. So you have to look at the lateral meniscus, and sometimes intermeniscal ligament may limit the reduction or prevent reduction, which has to be cut. So this is a short surgical technique of this particular problem, and after surgery, you need a good reduction. And if there is an anterior lifting of the fragment, it may prevent extension of the knee. So post-op rehabilitation, it's similar to ACL reconstruction. Previously, prolonged immobilization was used, which caused arthrofibrosis, permanent loss of extension and stiffness. Now the prognosis is good because the mobilization is early and all arthroscopic technique is used. First 2 weeks, toe touch walking and weight bearing, partial weight bearing, slowly progress to full weight bearing. Modify it depending on the fracture extension and your preoperative planning for the tibial plateau. The complications are delayed mobilization means arthrofibrosis, loss of extension, stiffness, and laxity is one issue for early mobilization. So it all depends on how well you fix the fragment into the medial cortex of tibia and how much perch or how much stiffness the suture material has got. Loss of extension is due to a notch impingement, and during arthroscopy, look for extension of the knee especially, and inadequate reduction or loss of reduction leads to lack of extension, which has to be kept in mind. And this is all about my presentation. Thank you for giving me this opportunity once again. This is the conclusion. All arthroscopic fixation of the ACL avulsion is a gold standard. Pull-through suture fixation has stood the test of time. It is easy, it's predictable, and no arthrofibrosis. Thank you.
Thank you, Gopinathan. I have a question for you. There are many techniques for fixation of ACL. I'm not going for in technical detail, but most complication what I have seen is arthrofibrosis. What percentage of cases you require manipulation under anesthesia after arthroscopic ACL avulsion fixation? Because you said that there is no arthrofibrosis in your technique.
This is because we give a good post-op analgesia in the form of a femoral nerve or a lumbar plexus block, and
what
pain
percentage
relief is the most. That's what I told.
So you have the 100% cases don't require manipulation under anesthesia.
No case will require. If you give good post-op analgesia, if the post-op analgesia is not good, definitely around 20 to 25% will go for arthrofibrosis and will need manipulation under anesthesia. But if you give a very good post-op analgesia, no patient will need arthroscopic. Patient will develop arthrofibrosis and they will never need a manipulation under anesthesia because pain is the stimulus for fibroblast regeneration. When the fibroblasts are increased, then it goes fibrosis. Intra-articular fibrosis, the beginning is the pain. So if you can give an excellent pain relief in the post-op period, no patient will develop arthrofibrosis. So it all depends on how much post-op analgesia you provide and how early you start your mobilization. If you start mobilization late, then it definitely results in arthrofibrosis.
Yeah, go ahead.
And delayed mobilization.
Gopi, it was a wonderful video technique. Gopi, this is Dr. Roshan. This is a wonderful video technique of ACL avulsion. What I just want to know from you is when you do this all inside repair for ACL avulsion, you take only anterior sutures or you take any posterior sutures in the form of anchor, or do you create a double row or a suture bridge type of repair technique, or it's a simple pull out for a unidirectional pull out for the ACL?
This is a single unidirectional pull-out. It's not all inside arthroscopy. We do for some cases all inside technique where you put suture anchors into the crater and then tie it to the anchor. And additionally, we put two sutures on either side. So pull-through sutures plus all inside gives excellent result. But most of the cases will not need that. And some surgeons just do all inside with suture anchors only. But it all
We at
depends on how
KM Hospital, we have studied the three patterns of ACL avulsion fixation, where we have done a double row repair, that is you create anterior and posterior repair so that you get a better stabilization of fragment inside the crater. You do single row repair like what you have demonstrated now, and then you create something on a suture bridge, right? Crisscross, creating a very firm type of repair. And it has been studied that when you do a double row crisscross, that is suture bridge type of repair, it is more a stable fixation of the fragment into the crater, and the chances of non-union is very, very less as compared to the single.
That's great. That's a great technique.
Yeah,
Fully
because,
agree with that.
because the single row repair, you can have the lift off mechanism whenever you do a knee flexion. The fragment will be posteriorly lift off, and that can go in non-union. And the delayed lift off non-union is the commonest problem with ACL avulsions.
One of the disadvantages of this technique is anterior lift off. Actually, the anterior fragment will get lift off and it will result in a block in extension. And this can be avoided by double row or addition of all inside technique with suture anchors. So it all depends on how much stability you have achieved. You pull it and see. If you have a good stable fixation with this single row technique, then you can stop there. Or if you feel that it is not good enough, then always you can put an anchor into the crater and then tie it. You put it just anteriorly so that there is no anterior lift off of the fragment. That's an excellent technique.
Yeah, it is true. As Roshan what is told, and intraoperatively it falls into crater, and later it may displace. Depends on the stability. Yeah, sometimes it is a small fragment. I think I go for a single, and if it is a big fragment, sometimes the entire threads will slip one side and gets no flip off, flip out at medial or lateral or anterior, posterior. So, what type of suture material use? Fiber web or fiber tape?
Initially, we used to use Ethibond. Nowadays, we use fiber web.
Okay.
Okay.
Hi, Jaya, this is Dr. Samantha from
Yeah, Samantha. Tell me. Samantha, go
thing
ahead.
is that probably I completely agree with Roshan and my dear friend Gopi. The fragment size will decide whether to go with the what sort of fix. If it's a small fragment, then you can just make two drill holes and it is okay. But if you find it's a big fragment, then if you just go in front, the posterior fragment will lift off anyhow. So it is better if it is a fragment size is big one, then you have to go with the double row sort of fixation or the speed bridge sort of fixation. Otherwise, the posterior fragment will lift off. It is a big one.
Thank you. We'll go to next to talk Dr. Swarn. Anyone wants to? Bhupesh, anyone? Do you want to ask question?
Sir, regarding the suture material, I had a doubt in patients who are skeletally immature. When we use suture tape or fiber wire, theoretically, I am always scared that there might be growth arrest because these are very strong suture material and they don't expand or degrade. What is your protocol? Do you go back and remove the knot after 6 months, or do you allow them to stay? I have not seen any growth arrest, but theoretically, I'm very scared, especially when we do double row and multiple tunnels with fiber tape or suture tape in skeletally immature patients. What is your protocol?
Fiber tape is out of question here, Bhupesh. Fiber tape is out of question. Don't
Can
use
I
the
answer
fiber
this?
tape. Roshan, your task.
Yeah, so I'll share you my experience. I had an experience of two cases where I have operated these two patients for ACL avulsion in year 2010 and 2007, I think. And later on, both the patient they required ACL reconstruction because they landed up with repeat surgery. At that time, when I did an accidental ACL diagnostic scopy, and I realized that this non-absorbable sutures, especially those time it was ethibond, and later on we started doing the ultra bed. And these sutures were completely fibrous and there is no attrition at all. So they remain for years without any symptoms. Bhupesh. So
No, he is asking whether there is any problem in the growth.
yeah, and there was no significant growth arrest. Those were both the kids which we operated, and later on they became adult and they damaged their ACL again. And we landed up in doing ACL reconstruction. The fragment was completely well healed, and the patient didn't have any deformity in any kind, because probably we operate in the central area of the physis. There is no damage to the physis. Plus, we don't create a bigger tunnels. We just create small K-wire tunnels, so that the damage will be very less. So unless you are doing a ACL reconstruction where you require 8 millimeter, 9 millimeter tunnel.
Roshan sir, my question is not about damage to physis. This forms a fixed loop around from the articular surface to the anterior tibia, and this fixed loop does not expand with growth.
Yeah, that could be, but
talking about it is the stability of this construct that we are doing in very young children. So I'm always theoretically scared. So in 6 months, I go in and make a small nick anteriorly and cut the thread in the front where your anterior suture knots are made. Because this is a theoretical doubt. I've never seen any kind of problems. If anyone in the panel has faced this difficulty or what they think of this is what I wanted to know. It's not the physical injury at the time of surgery. It becomes a fixed structure that we create, and it does not expand, as you said. In your revision cases, you have seen that they are still there inertly without fading off. So that was my question.
No, I think Bhupesh, I have never gone again at 6 months. I never removed or cut any suture, but I never repented for that. I think there is an extra bit of surgery. You don't have to scare for that.
Okay, sir.
Yeah. Maybe guys, we'll go for the next talk by Samantha.
Yes, my talk is in the loop.
Yeah, arthroscopic PCS.
Today I'm going to present the all arthroscopic technique, how we do the PCL reconstruction. Okay. So whenever we start doing the PCL, the clinical examination is mandatory. Okay. And also you must do all the necessary investigations like your X-ray and your MRI. And now this, if you see, if the ACL is intact and the PCL is gone, you will say this is known as the lax ACL sign. We'll tell you that only the PCL is gone. And before PCL, I will request everybody that please don't miss the corner injuries, like do the dial test, so that you don't miss the posterolateral corner injury or the anteromedial injuries or the collaterals. So this is the way how you take off all the PCL remnant. And the best way of doing the posteromedial portal is that you take your spinal needle and you take the spinal needle to locate the ideal portal. And I will request that whenever you do the spinal needle, you must know where is the femoral condyle, medial femoral condyle, and the joint line and the tibia, and then make the full light inside the OT off, so that if you put the lens over there, you will know that this is the ideal location. And once you locate that, and then you have to use the Wiesinger rod or the switching stick, then you can put the cannula on the backside, the posteromedial portal. Sometimes nowadays people are doing like the 2 portals on the posterolateral side. Some people even are doing the transeptal technique, like the 1 posteromedial and 1 posterolateral. But if you do the 2 posteromedial portal, 1 for the viewing and 1 for the walking purpose, I think this is great for the PCL reconstruction. Here, my saver is from the posteromedial portal, and I am saving off the posteromedial, the rest of the remaining stump from the tibia. Okay. Now, if you can see, then whenever you save off, you have to go up to the Sampen drop, so that you take off all your PCL remnant from the back side of the tibia. Now the scope is on the posteromedial side, and the PCL tibial jig is coming from the front. And now you will see how the breath pin is coming, because it is guarding the between. And when you see that when you feel that when you are drilling that you are just going to be out of the tibial backside, don't try to run your drill. Just go on simple small tap on the bead pin, and so that it goes very slowly, because your all the important structures like your all the blood vessels and the nerve is hardly 14 to 15 millimeter away from your tibial posterior surface, and you do it and 90 degree of flexion. And now I see with the curate I am protecting the bead pin, and now I am making the tibial tunnel. And this is also very slow process. Don't overshoot. It is like your stop and start, so that once you are going out of the tibial posterior surface, you have to be very careful. Then the loop is passed from the back, from the front to the back, so that you can take the loop. You can use the stainless steel wire, you can use the Ethibond, so that you can take the loop from the back side. Okay, so now I am taking the loop from the back side and it is putting to the back. Now you see we have to take the femoral tunnel for the PCL, and you see there are some marks over there, 5, 6, 7, 8 marks. So if you see 90 degree, this is the high side on the 12 o'clock, lower side of the 6 o'clock is the lower side, and it is shallow and deep. It has to be the ideally on the high and the deep side, high and deep side. Okay, so now I am coming from outside in technique. You can go from the inside out technique also, but when you do the outside in technique, always remember to palpate where is the medial epicondyle of the femur and where is the superomedial corner of the patella. So basically you are in the middle of it, because if you are too close to the medial femoral condyle, you can blow out on the front side, and that is a great complication. And sometimes there are reporting that if you are very close to the medial femoral condyle on the front, that medial femoral condyle even go into avascular necrosis. So you have to be very cautious when you do the outside in technique. You can go from the inside out technique also, but here I am showing you the technique how I do in the outside in technique. Now remember, this is a very important step. Before pulling the graft from the tibial side to the femoral side, always put your needle and wire from the front, because it is very difficult to find the space or the hole on the outside once the graft is in. So the needle and wire will be in the front of that graft. And sometimes you can use the Wiesinger rod just to negate the killer turn, because your tibial tunnel is 15 millimeter down from your tibial margin on the back side. Okay, so usually your graft for the PCL is 10 millimeter. Is the best graft is around 10 millimeter. Okay, so never compromise like 8 millimeter or 9 millimeter. Okay, so now you can see the graft is inside, and my needle and wire, which is coming from the outside and in, it is at the front of the graft. So now we are fixing with the bio screw, and we can see from the inside that the bio screw is coming and fixing that. And the best way of knowing that how much graft is going inside, you have to mark with the skin marking pencil, or you have to some mark on the graft, so that you don't pull too much of graft inside the femoral tunnel. That is no need, because if you just put on 20-25 millimeter of graft inside, that is more than enough. And remember that whatever graft you put, even the ACL or PCL, this tunnel or the mouth healing is the maximum. That is the Sarpe fiber which goes. So your tunnel should not mismatch for your graft either in the ACL or PCL. So now my PCL is fixed on the femoral side. Now the graft on the tibial side is fixed with the bio screw. You fix with either 1 or 2 up according to the quality of the bone at 70 degree of flexion. And remember that it has to be the anterior drawer, and always check before doing that on the normal side what is the relation between the femur and tibia, so that you can recreate on the normal side. So once you do that, you visualize the graft this way. So 70 degree of knee flexion and your anterior drawer so that you recreate whatever was there on the normal side. Thank you very much for your kind and patient hearing. Take care.
Samantha.
Yes.
Roshan, any question? Roshan, you wanted to ask question?
Yeah, Sorendu. Sorendu?
Yes,
Yeah, I was just observing your video, and I had 2 points to make on those video. One was the removal of complete stump of PCL. Do you remove the complete stump of PCL, or you do a partial augmentation and try to retain whatever fibers of PCL are intact? Because I think during your first session of your video, there are some fibers which were intact in PCL and could have been retained.
No, I am not remove. I don't remove the full fiber of the on the femoral side. Probably I have seen that most of the fibers which is over there, I usually keep that for better healing. Because either on the tibial side I'm too aggressive, I remove everything from the back side. But on the femoral side I don't remove everything. Just I clear the spot where my drill is supposed to be coming in. I rest of the fiber I keep it there.
Second thing which I observed in your video was your PCL femoral tunnel. The PCL femoral tunnel looked like more of posterior rather than the anterior, which is should be very close to the anteriorly near the femoral cartilage.
Primarily when I was demonstrating, I was demonstrating with the jig, but when I take off, usually every time I do the femoral tunnel, I do take 8 millimeter as the mark from the articular cartilage. So I am just repeat this one. You go at 90 degree and there is a small point, and there is you can measure from that cartilage. You go 8 millimeter deep from the articular margin at 9 millimeter, 8 millimeter. So that it can't be wrong.
At what point you decide to do double bundle PCL or always do a single bundle?
No, I am happy with the single bundle. I can do double bundle. I have done double bundle, but again come back to the single bundle because if it is really to athletic people, I'll go with the double bundle. Problem is I'm happy if it is a sedentary guy. I am still happy with the single bundle. And if it is a single, only I am dealing with the PCL, not with the multi legs or the ACL and PCL. I still do the single bundle mostly.
What is your graft choice for PCL, sir?
PCL, whenever I do only PCL, I usually take consent that sometimes I can take both the grafts from both the sides. Because sometimes if you take the only semity and gracilis and you take 100 train sort of length, it is never suffices length. So if you do like only with the semity, it is better to have the consent from taking the graft from both the sides. Nowadays, if you are nowadays, as we have learned how to take the peroneus longus, because peroneus longus suffices your length and also your diameter. So you can do with the peroneus longus. But suppose if you are doing, probably we are doing the peroneus for last 4 or 5 years. Now, before that, I used to take the consent from the other side too. But never compromise on the diameter. As I told 2 times, it has to be 10 millimeter. It's not like 8 or 9. Even you can get away with the ACL with 8 millimeter graft, but it cannot get away with 8 or 9 millimeter graft in the PCL. It has to be 10 millimeter if you are doing single bundle.
Hello, AV guys, please go ahead. Next talk is ACL in pediatric by Karthik Selvaraj from Coimbatore.
I would like to
Thank you, Raghuveer. Thank you, Jaya.
Thank you, Swanendu.
give a talk on lethargy procedure. The objective of lethargy procedure, like any other instability surgery, is mobility and stability.
Every guy, the topic is
Karthik. AV guys, please stop.
In the Indian scenario,
AV guys, please stop this talk. Yeah, this is shoulder. Where we are is in knee. Please take the knee talk, not the shoulder.
ACL in pediatrics. Karthik has 2 lectures. One is in shoulder session and one is in knee session. So take his talk from knee session. ACL in pediatrics, Karthik.
Karthik, are you in live?
Yeah, yeah.
Then
Yeah,
you
can you share your screen? Do you have PPT?
Yeah, yeah. Ready.
Yeah, go ahead.
So please unshare AV guys your screen and let Karthik share his screen if you don't have his lecture.
My lecture was ready actually.
Yeah, go ahead.
Okay, Karthik. Good.
First of all, I would like to thank the and all others for having given this wonderful opportunity to me. Are you able to see my screen?
Yes,
are you able to hear me?
Yeah, we can hear you, Karthik. Go ahead.
Go ahead, Karthik. Go ahead.
Okay. So I'd like to thank my colleague, Dr. Arul Daniel, for the preparation of these slides. ACL in children used to be called very uncommon. Historically, we used to say that ACL injury in children is quite rare. But what has happened in recent times is that younger children have started playing very aggressive sport. The parents are very pushy. The coaches are very pushy. The children are put into supraphysiological loads. So what has happened basically is everyone is trying to do more than what they should be doing. So the ACL injuries have increased in children. Now we have better imaging modalities, so our diagnostic accuracy has improved as well. So ACL tear as such, ACL avulsion has been covered already. So I'm just going to stick to ACL tear. Now ACL tear appears to be very rare before the age of 12. Before the age of 12, you see a lot of cartilaginous avulsions, you see a lot of bony avulsions. Right from the age of say around 12 to 13 to 14, you see a lot of mid-substance tears. Less than that, age of 7, 8, and 9, it's mostly avulsions. And we are very good in fixing avulsions because we have treated avulsions in adults, and the same way you can do treatment of the ACL avulsion in kids. It's only thing we have to be careful about is not to damage the physis or go through the physis with a very big drill hole, which is unusual when you are fixing an avulsion. But when it comes to a ACL reconstruction in a kid, it's a different ball game. So mostly it's a sports injury. Usually they present with pain and swelling. Many times there may not be any instability, and there could be some difficulty in weight bearing as well. Now the problem here in diagnosis is that the physiological laxity is quite high in children, and frequently you find in these patients, if there is an ACL tear, you usually find that their pivot shift is positive. Now a study of hemarthrosis in children has shown that 1/3 of these patients are ACL tears, but rest of the 2/3 are not ACL or any other ligamentous injuries. Now look at this MRI. This is a 9-year-old boy's MRI. In the MRI, if you can see, the ACL is actually parallel to the proximal tibial physis. Now this ACL is not torn, but if you look at this MRI, it looks like as if it is the intensity, the signal intensity. Looking at an adult MRI, we can misdiagnose this as an ACL tear, but this is a false positive case. So the false positive rate is about 25%. So beware when you're diagnosing an ACL tear in a kid. Now, I think everyone knows that we need to find out the skeletal age of the child. Now, the best ways to do is to get a hand X-ray. And if you have an iPhone or an iPad, you can download the Bone Age app. The app actually, you can upload the wrist X-ray and then gives you the approximate or almost the accurate bone age of the patient. Now, once you know the bone age, now you can treat the patient according to the age of the patient, the remaining age, even remaining growth of the patient. Now, non-operative is almost out because the problem with non-operative is it's very difficult to monitor the children of this age. Now, the coaches and the parents have to really understand that non-operative management means it's a lot of strengthening, a lot of restraint from any sort of physical activity for a long time. Now, there is one paper saying that at 1 year after a very structured non-operative therapy, the outcomes are good, but then it's very difficult, especially in the Indian scenario where patients can be easily lost to follow. So to avoid any irreparable meniscal tears, better to actually operate them early. Now, if you operate them, it's also shown in literature that the return to sport is better. Now, operate, but with caution. So the surgical technique basically is there's a physical sparing technique, which can be basically an extra physical technique, the Meninder coach's technique, where actually you leave the distal stump of the hamstring. you don't touch the, so you don't touch the origin of the distal attachment of hamstring. Use an open stripper, harvest the hamstring, take it behind the femur in the over the top position, and then fix it above the physis either with a stapler or with a screw post. It's a very straightforward surgery. It works quite well. Anteriorly, you have to take it underneath the intermeniscal ligament. That's the only thing you'll have to do. And the other type is the all epiphyseal fixation, where you actually fix the ACL graft to the tibia on the tibial physis and the femur on the femoral physis. Again, this is technically little challenging, but can be done as well. But this is in children less than 11 years of age. 10, 11, this is not a very common presentation. Many of these children do not have this tear. They usually have an avulsion, which is easy to manage. But if you get a child who is 9, 10, or 11, you should be thinking about a physeal sparing technique. But you get a 13-year-old or a 14-year-old, then you can safely do a transphyseal technique, which is actually very similar to an adult surgery. So it's not very difficult. So this is the coach's technique, where it's just like a very traditional Marshall McIntosh technique. The only thing is you don't drill a tibial tunnel. You just take it underneath the intermeniscal ligament, and then you just bring it out over the top and then fix it back onto the tibia if you want, like an additional ALL. So again, this is a very, very reliable technique, good outcomes, low revision rate, low chance of growth disturbance. Now, the all physeal technique, you need a C-arm. And again, it's not a very difficult procedure. You can do it. And this is an example of such a patient where this is an MRI. You can see there is a tear of the ACL. Just run through it quickly. Now, this is the ACL tear just being debrided. Under the C-arm guidance, you just make your tunnel. Tunnel is basically in the physis of the femur. So once that is done, actually you pull the graft out and then make a small incision, tie it over a button there, and that's the graft exiting out. Fixation on the tibia could be either a button, fixing or you can use a screw. So all epiphyseal technique, again, the outcomes have been good in literature. Not a lot of patients. There are very limited number of patients in all the studies. Again, when you think about a transphyseal technique, basically the only problem is it violates the physis. There could be theoretically compression across the physis. Physeal arrest and angular deformity. We are worried about a recurvatum deformity or an angular deformity, like a valgus. Valgus and recurvatum is what we are worried. This is very rare. In literature, it's about 2 to 3%. But if you are very careful, you can definitely avoid this. Now, this is a 13-year-old football player. If you see, he's got an ACL tear and a meniscal injury. So that's the setup. You got a C-arm, and that's the ACL tear in this child. So here, the precautions we take is that we make a fairly vertical tunnel. Don't worry about anatomy. Now, let him finish his growth and then come back to you. If he has a symptomatic ACL, again, you do a more anatomical surgery later. So right now, you're worried about not damaging the physis too much. So that's the lateral meniscal tear. The meniscal tear can be easily repaired while you are there, and that's what you're really there for. You don't want this meniscal tear to become bigger at this age, so that the knee becomes symptomatic very early. And this is a straightforward technique. You just be vertical. Don't put a big graft in. Put a 6 to 7 mm graft. Definitely a soft tissue graft. The bone should not cross the physis. And you can use the traditional button fixation on the top. And then the only thing is you don't want any screw passing through the physis again. So make sure your fixation is such. Now on the tibia as well. And so that's the principles. Again, I've stressed it. Graft fixation should be away from the physis. You can use either a screw or you can just use a poster in the tibia. Button on the femur is safe. Soft tissue graft. Don't tension the graft too much. That's very important. Now, there have been case reports of very severe growth restrictions in patients who have had an ACL as a child. So take all precautions if you're operating one, because we don't see them very often. You don't see them very often. It's not like an adult. So always operate irrespective of age. Make sure that you do a good surgery. Condyle and meniscal damage can be prevented. Can conserve if everyone is in the loop, but it's very difficult. Assessment of skeletal maturity is very important, and then do the appropriate procedure to get the results. Thank you very much.
So we'll continue the
Karthik, there was a wonderful
Roshan,
talk.
any questions, Roshan?
Yeah, can I ask questions to Karthik?
Yeah.
Roshan sir.
Yes, Karthik. That was a wonderful talk. In fact, wonderful video demonstration. Karthik, when you go all fascial, are you worried about the heat necrosis very close to the fascial growth plate, which can be created during transverse tunnel on the femoral side? Because I think the femoral tunnel is the one which gives you more angular deformities if they have to be. It's not on the tibial side. So, are you worried when you do a transfascial, the all epiphyseal femoral tunnel,
Definitely.
about the thermal necrosis created by your tunnel in the epiphysis?
Definitely, sir. That's the thing. So it's in a very young child, we have no other option. If you have to reconstruct, then you do this. But as you said, you have to be aware that high power will be very close to the pulses. There is definitely a chance of necrosis.
There is a wonderful technique which was designed by Dr. Stefano Jaffazzini from Italy. In fact, he had a demonstration live surgery in Mumbai.
Yeah.
That time he demonstrated a pediatric ACL reconstruction in a 11-year-old boy. Done the over-the-top position reconstruction of the ACL, non-anatomical, and then he continued the graft on ALL side. Completely the other way what Mininder does. Mininder does it from outside in. He does it from inside out.
Yeah,
And then he continues that as a ALL
Yeah.
and fix it. So there is an additional fixation in the form of ALL so that you can avoid that thermal necrosis which can lead to a severe angular deformity on the femur.
Definitely, I agree with you. Actually, I visited Stefano in Italy. Stefano does this for all his adults also. He does the same procedure for adults. Only thing is he makes a tibial tunnel in the adult. So he actually harvests what I described when I spoke was actually Stefano's technique, where you use an open stripper, take the graft, pass it underneath the anterior intermeniscal ligament, take it over the top on the femur, bring it out through a lateral incision. If you want, you can fix it there with a stapler just above the physis with a small staple, and then bring the remnant graft down below to the tibia and then fix it again with a stapler. So that's technique which he does even for the elite football athletes in Europe. I think a lot of people have had that done. So which is popularized by his mentor Marilla Marcaci and Stefano Zaffanini. It's a wonderful technique. I totally agree with you. And if given a chance, I would do that rather than doing an all five cell technique.
Thank you, Karthik.
Thanks, Karthik.
The next talk is by Dr. Jagdish from Bangalore. It is all inside ACL. Dr. Jagdish, please go ahead.
Yeah, hello. Hi,
Yeah.
good evening.
Yeah, good evening.
I thought they are sharing the screen.
I'm sharing the screen, sir.
Hi, Dr. Jagdish.
Yeah, hi. Good evening. It's a nice talk.
You can start the Dr. Jagdish talk.
So that is a very surprising. So after the good talk of about this, and we are going for all inside ACL reconstruction. If you see in a Google to know about all inside and newer techniques, you get to get all these things. There are some things new about the percutaneous ACL repair and the internal brace, and some of the features, the conventional ACL reconstruction and why it is failing. So that is a very surprising that though the ACL or reconstruction with an all-inside technique started very early in 2012, what are the techniques which have been advanced, though, but it is in 2000 till 17, the people started accepting this all-inside ACL reconstruction. And if you see that, why the people are just moving from a conventional ACL reconstruction, maybe it can be due to the market your ACL reconstruction techniques so that you are successful. And also you can see the lot of complications which they emphasize about the conventional ACL reconstruction. Some of these techniques which could be screw irritation, and which is pretty common in a bio-interference screws. And few techniques which you can see, there is an intra-articular screw migration, and there is a lot of papers which have been reported about the bone tunnel widening, and of course a few of them about the reduced bone tendon interface, and also the screw breakage, which is a pretty common in the initially stages, but slowly it has been taken. And what is this all inside ACL reconstruction technique? So this is, though it has been evolved in 2012, it is a relatively a new development in ACL surgery. And some features of this technique, it includes the socket, so creation of the socket. So the tunnels are not done here. And there has been a suspensory devices which were used both at the proximal, the femoral side and the tibial side, and the decreased bone removal. And of course, there is a smaller skin incisions. If you look at the development of the anti-cruciate ligament reconstruction within all inside technique, it was done by Morgan et al. In 1995. So he used a high medial portal to drill the tibial socket inside out and used the interference screws to fix the graft. You can see this. And these techniques never gained popularity due to its technical difficulty.
I think they have developed the new one. The old previous one, they have said it. I can just start talking myself. So there's the development of the retrograde bias screw was now started in 2002. It was Morgan et al. And then now just after getting on to the initial what he was thinking about from going from antigrade, that from the top to the bioentrance screws, he started developing the retrograde putting the bio screws. Though it was not a truly all inside technique, so because there was a full tibial tunnel which was prepared completely. So, but this technique which gave the way for to development of an all inside procedures. Next slide.
Heavy guys, next slide please. Heavy guys. Next slide, next slide. Because video recording.
Some of the failures of a conventional reconstruction.
Next slide.
It started evolving the.
Heavy guys, next slide, not this slide.
So what is a
next slide?
Next.
Yes. Yes, previous one. Yeah.
Yes. Stop it.
So in 2011, there was development of second generation flip cutters. So, which was used for all inside technique, and this was called a graft link technique. So the graft is fixed both the sides by a cortical suspension device. And initially there was a ACL tightrope, and then later they came as development was on the ACL tightrope reverse tension RT. And these are the devices, the suspensory devices, and which is the cortical suspensory devices, are instrumental in the evolution of the current graft link technique for an all inside ACL reconstruction. So here I'm showing this two small video of about how the all inside ACL reconstruction technique is done. And the mainstay of this all inside is the graft link technique is the how you prepare the graft. If you look at it, so because of the length which you don't need to it, so a short tendon is graft is more than sufficient. Say about 260 of the graft is more than sufficient. And sometimes you can take only the one single graft, that is semitendinosus. And once if you take the graft, you're linking it the end to end and through the loop. So that is why it's a link, the graft link. So you've got already a loop on the either sides, and you're linking it, taking the loop around the loop of a ACL tightrope and then suturing it. And suturing is very important here because all the strands has to be covered, and usage of number 0 fiber wire is very important because it should not be too thick. And so that because the graft interface to the tendon or to the bone has to be important. The bite should be only the few bites. And once if you're done with the graft preparation, that is an adequate of about 60 is more than sufficient. The arthroscopy, you will locate the pilot hole where your ideal placement of the femoral tendon has to be there. Here, what I don't use the regular flip cutter for the femoral because I use my own technique of the regular from inside out technique. So this is an all inside only. This where I'm just drilling from there. So it avoids me doing it from extra from outside femur. And here you can see that the tibial side jig is being used, and the ideal site of it is that is at the length along the line of a lateral meniscus on the line. And once if you just get a proper, so sometimes you need to use a different colors for the ethibond of ethibond. So that you do not get it confused in while taking it out, and it has been retrieved through the anterior medial portal. And once it is retrieved, your graft placement will be there inside. And you should always make sure that your flexion and extension should be there, without any notching. So your ideal length of the graft at the femur could be around 20 mm. If you have a length of about 65 mm of the graft. And for the tibia, it should be around some 20. So it could be a 40, and remaining intra-articular, you'll be having some around 20 to 25 mm. So for a graft about 65 mm, this is a very much placement. So what happens if you do not have the graft of ideal? So suppose if you mismatch, then there will be slacking effect in the intra-articular region. So this should be avoided. So calculation of the graft is very important while creating a socket. What are the advantages? It improves the cosmesis by eliminating the larger incisions. And of course, by creating a socket, you are preserving the bone. And the pain will be less because you are not breaching the cortex and you are not violating your periosteum. And since it is filling circumferentials of the socket, the healing of the graft to the bone is very good. And if you're doing it a proper regular technique, which is done by Lubovitz, you don't need to do an hyperflexion because there is a separate jig and separate flip cutters will be with to retrieve the ethibond or whatever this is from the inside. It's available, so you don't need to do hyperflexion. And sufficient, if you have got only semitendinosus, is more than sufficient. And one of the advantages of this and all inside technique is you can use the fiber tapes, which gives as an internal bracing. So this gives an extra additional support for your reconstructed graft. And it is locked at both the ends in an all inside manner. And sometimes you may have to use it, a swivel lock, to have a backup fixation at the tibia. So what are the advantages in this augmentation of the graft. You have got a protection from accidental acute loads, protection from stretching, and you can rehabilitate early in an athlete's, and it's got a special value in small and thin tendons. Disadvantage, learning curve is difficult. Biomechanical results are a little bit inferior compared to other things. There is a windshield wiper phenomenon, and there's a chance of extraarticular break. Thank you.
Any questions from other faculty? Samantha sir.
Thank you, Jagdish, for the nice presentation. I have done with this all inside technique, but that very good. But that it takes bit of time, so most of the people are not. But I recommend this technique is a good one.
Yes.
Jagdish, one question, practical question.
Yeah, please.
If you have a mismatch intraoperatively with your sockets, both sockets and your graft, so you are stuck inside with a lax ACL, and how to come out?
Yeah, that is what I said. That shouldn't happen. That shouldn't happen because you're mathematically you should be ready so that you have to drill a little bit extra socket to unduly stop this, the laxing effect of the intraarticular, the graft's length. So I haven't experienced of this. In case if it happens, what I will do is I will usually take an extra drill that for the tibial side. I will make sure that I will use an extra socket to creation some more, much more, and flip to and try to pull the graft a little bit down, and use an swivel lock to as an extra the strength to have an extra articularly.
Jagdish, and
Jagdish,
another one suggestion.
can I ask you a question?
Yeah, please.
Jagdish, nice presentation.
Yeah.
I have one technical question and related to the long biomechanical study of ACL reconstruction.
Yeah.
When we see the suspensory fixation, especially on the femoral side,
yes,
if we study the long-term studies of all the suspensory fixation,
yep,
there is a bungee effect which is created on the femoral side because of distant fixation. Now you have both side distant fixation on the femur as well as tibia. So do you think this is lead to a double bungee effect and eventually the laxity, which is say around a small laxity which persists, especially in all inside cases, as regards to the cases where you use only one side bungee effect and other side is a interference screw fixation?
Yeah, that's a good question, Dr. Roshan. See, actually, yeah, if you think about the literature, there's a lot of bungee effect and tunnel widening and all. But when we see that the ligament interface happens within six to the bone within 6 months, and then the strengthening goes near to 1 year. Here, what we are advocating, we are not taking the 25 to 30 mm of the graft to the bone. We are taking only 20 or at least in 15 also is sufficient. So we know that the graft interface do not happen within the complete the tunnel. It's mainly the sharp piece fibers. So those sharp piece fibers, if they protect for some time for us, definitely what the literature says about the bungee effect is not going to happen. And as I said, it is at the 20 mm or less than 25 mm, 20 mm in the femoral side and the tibial side do not get as like bungee effect as we are thinking about what the literal. Theoretically, we can think about the bungee effect can happen, but by the time the graft would have been healed very well, and we are not. I mean, as I'm started this technique from 2012. The moment 2011 this technique started, I started it, but I haven't seen any laxity because here I get a good fixation. There is no slippage of the graft happening, and I mean the socket filling is very well to the bone. So that is the one which I will be happy to do this always, and my 90% of the cases will be in an all-inside technique.
Dr. Jagdish, just just small query. As we do all inside technique, usually use the drill from the outside in so that we can measure on the femoral side and the mathematical calculation much more accurate. So why you do your inside drilling for the femur? Because
Yeah.
you drill your all the mathematical calculations are extremely accurate on the if you do classically follow the all inside technique for the ACL. Why you change this way?
Yeah, because here also my calculation is not going to have a difficult because anyhow even our drill has got the whatever the length we have got it. So even here also I'm going to drill whatever we wanted. Only thing is why I change this. I do not want to have an extra articularly. I mean from outside to in which come in to drill and to locate it, the another strand, I may have to take spend some more time. Here, I don't need all these things. From regularly conventional, the femoral side, if I start drilling it, if I put a socket, I have a good length of how much drill I'm going to do it. So I don't need an extra time of getting it from the outside in technique and identifying the strand, the ethibond and pulling it from outside.
But Swarnendu, coming back to your main question, outside in better or inside out is better for femoral tunnels? I feel outside in is 1,000 times better because it creates a real socket.
Yes,
That is
yes.
one. The tunnel of your mouth of the tunnel is not the oblong tunnel. The tunnel. Secondly, it is a more anatomical rather than your non-anatomical. This thing, you cannot be wrong when you go outside in. You can be wrong when you go inside out. Even the 2 millimeter wrong placement of the pin will lead to non-anatomical placement of your graft. Wherein outside in, the accuracy rate is very, very high. So probably we all are not trained with that outside in technique, but I totally agree. It is one of the best technique to do it.
No. This is very easy one, because there is a height for that. It is a measure on that. And problem is that if you go from inside to out, you cannot locate the accurately. Cannot be oval hole. Rather, you will have a oblong hole which will never fit, and you will never give this Sarpe fiber theory. That is the problem with the inside out technique.
Yes, these oblique holes.
Zubair here. Right. I'd like to
The
add
last question.
Go ahead.
I see. See, basically, the outside in jig is much quicker and faster because you don't need to put a guide wire then reamer, no? A single step if you use a flip cutter.
Yes.
I'm using it flip cutter for all the cases and up and down.
It goes in and out in one go.
Even for PCL, I feel better, but I think maybe in your hands you feel better with the inside out.
No, as because Jagdish is doing for last 8 years, probably he is more expert than us. But probably if I do it all inside, I'll do it outside in for the femur.
I always do the same technique. In fact, all the jigs they have introduced, there are 3 types of jigs they have been introduced by Arthrex from 2010. But still, I feel it is better like if you use a flip cutter on the femoral side also. That's my personal experience and opinion.
Yes, Sunil.
I completely agree with you.
Graft size, Dr. Jagdish?
The graft size usually what I get around 10 mm. Here, I do not use only SEMITI. Sometimes I use the gracilis also. So I will have 2 grafts, such as SEMITI as well as a gracilis.
Jagdish.
Yep.
You are saying that if the tension you are not able to adjust, you want to undo it, you should have to drill it. But today, I think we got some more companies have got launched, maybe Conmed, where you can readjust the loop.
Yes.
So that still we can manage with it.
Yes, still we can manage it, definitely.
We'll go.
Yeah, we'll go for the next talk. That is extra-articular tenodesis with ACL by Dr. Rajkumar Amravati from Bangalore. Here you guys, please go ahead.
Good morning, I am Dr. Rajkumar from St. John's Medical College, and my talk this day would be on lateral extra-articular tenodesis. Here you can see on your screen a double PCL sign suggesting that there is a bucket handle meniscal tear, and also he has an ACL injury. Would the viewers do only an ACL reconstruction and a repair of the bucket handle tear of the medial meniscus, or would they add an extra-articular procedure to augment your reconstructive procedure? Is a point that everybody would want to think about in the next 10 minutes of this talk. Sigondo was the first who told us that there is a presence of anterolateral injuries when ACL is injured. However, the concept of anterolateral rotatory instabilities were given to us by Slocum and Larson in the year 1968. But the anatomy was elaborately studied by Houston and his group, who said that the middle third of the lateral capsule is really like a ligament and it accentuates the ACL injury. But when we look at the literature that is available for us to really decide what has to be done, there is paucity of the literature, and there were only 5 studies which we could put our hands on to say that the lateral extra-articular procedures or the anterolateral procedures really influence ACL surgeries. Historically, Macintosh used IT band in this fashion to reconstruct the lateral side and influence the outcome of ACL surgeries. Whereas Meraki used the semitendon in this fashion to reconstruct both the ACL and the lateral structures, whereas Ellison rerouted the IT band under the lateral collateral ligament in this fashion to augment the anterolateral instabilities. However, the biomechanics were well studied by Luz and his group, and he really gave a crux on how the mechanics change when ACL is injured. The mechanics will change when the ACL is injured is that the forces are shifted on the medial side when ACL is injured, and you need two arms to shift this force from the medial compartment to the center of the knee. As a result of which, an extra-articular procedure and ACL would be the right way to go to shift these forces back to the center than the ACL reconstruction alone. So if you are looking at the indications for this procedure, Cotet and his group have classified it into two main headings. The main headings would be the ACL revision scenarios and grade 3 pivot shift injuries, along with hyperlax individuals with highly contact sport playing athletes. Also, the second indication would be when there is a presence of a notch sign in the X-ray or on the MRI, and an young individual with a sporting injury like a contralateral ACL injury or a same-side ACL injury. Early results with these procedures were done by Dijur and his group, and they found that good results were seen when they added extra-articular procedures to their ACL reconstruction. However, for 20 years between the 90s and the early 2000s, there were controversies between the North American and the European group of people who were really dwelling on the pros and cons of this procedure. However, it dawned upon Zavagnani and his group to bring light to this particular procedure, saying that the return to sports was much better if an extra-articular procedure was added to ACL injuries. That is when everybody started doing lateral extra-articular tenodesis, and it is done in this fashion. The fibular collateral ligament is identified, the IT band is railroaded under the FCL, and then a tunnel is drilled behind the lateral epicondyle in this fashion, and it is fixed with the help of a bias screw. Vancomycin to be used to prevent chances of infection. In our study, early part of our study, we did around 10 cases, mainly associated with grade 3 pivot shift, and the notch sign was a guiding factor for us to decide that lateral extra-articular procedures to be added, and also the presence or absence of other associated structure injuries also influence the procedure that has to be done on the lateral side of the knee. Here is a young man who wanted to continue playing football, who had an ACL injury with a medial meniscal injury, and the X-ray revealed that there was no much of bony injuries. ACL injury was seen on this MRI, and a posterior tear of the medial meniscus was also seen. Now, after doing the ACL procedure or the initial ACL drilling procedure, the lateral side was marked for you up to 8 centimeters to harvest the IT band on the lateral side. In this fashion, the IT band is exposed for you to look at, and then the common peroneal nerve, the IT band, and the biceps femoris are marked for you to be in a safe zone. And Marcel Lemaire was the first, in fact, who used the IT band after drilling a tunnel behind the lateral epicondyle and rerouting it to the Gerdy's tubercle to augment the ACL procedures. A 1 centimeter wide and 8 centimeter long IT band is harvested in this fashion and whip stitched using ethibond, and then you can locate the lateral epicondyle by putting a loop around the lateral collateral ligament, and also the leash of vessels as well as the fatty tissue that is seen behind the lateral epicondyle will guide us to the landmark that is there in, for us to drill the tunnel for the lateral extra-articular tenodesis. And this is how we mark the lateral epicondyle, and you can see that drilling is being done on the lateral side using the bead pin, and we have to be in a safe zone so that the tunnel don't coalesce, and you can watch the drilling of the tunnel by putting your scope through the index ACL tunnel so that there is no communication between the lateral extraarticular tenodesis as well as the ACL tunnel that you drill on the lateral side. The IT band is railroaded into the tunnel and it is fixed in 30 degrees of flexion and in neutral rotation using a bios screw in this fashion. And the wound is closed. This is the post-op X-ray of the gentleman. And if you have to look at the literature, why we do this procedure is in 90% of the cases of ACL injury, there is an injury to the lateral structures. The patients who undergo only an ACL reconstruction, as you can see in INE's papers, were not happy. And the extraarticular tenodesis anatomy is well documented by Noyes and his group when compared to the anterolateral ligament group. Having said that, you can see that the IT band, the superficial as well as the deep IT band influence the anterolateral rotatory instabilities when compared to only ALL in 30 to 60 degrees of knee flexion. When we come back to seeing the associated injuries that are happening along with the ACL injuries, an isolated ACL reconstruction doesn't really protect the medial meniscal repair. But when compared to the ALL reconstruction or the lateral reconstruction, the protection of the other structures are much better and lower failure rates are seen. Also, the pivotal shift that is seen in revision ACL scenarios, you can see that it improves when we add a lateral extraarticular procedure when we do ACL reconstruction. In these studies, we can see that all the procedures which were done on the lateral side definitely influence the outcome of ACL surgeries, which help them to control the rotation as well as return to sports are much better in these groups. Having said that, the great study done by the ESCA group, wherein we can see that all the authors like Zapagnani, Adrian Wilson, Samuelson, and all the group came to a consensus that good midterm outcome results would be seen with low failure rates and complications in ACL injuries if a lateral extraarticular tenodesis procedure is added. So to conclude my talk, I would like to say that the role of extraarticular tenodesis continues to be defined. There is an improved understanding of the anatomy and biomechanics of anterolateral capsules. Definitely helps us to augment our ACL surgeries, and quality clinical trials and safety and benefit of these procedures needs to be studied further to add to the armamentarium of our ACL surgeries. Thank you for your patient listening.
Okay, you guys go ahead with the next talk. MCL repair by
any questions? Are you taking any questions?
Yeah, after a few talks, we'll go ahead.
Okay. Yeah. Rajkumar, don't go. We have some questions for you.
Rajkumar is not there.
Rajkumar is not there.
Rajkumar is not there.
Yeah. He just ran away, what? So quick.
Bhupesh, welcome.
Good evening, one and all. I'm Dr. Bhupesh Karthik. At the outset, I would like to thank Team OSSCon 2020 for inviting me to this conference. My talk is on MCL repair. Medial-sided knee injuries are the most common knee injuries that an orthopedic surgeon sees, and luckily, majority of these do not require surgical intervention. However, isolated superficial MCL ruptures are common, and concomitant damage to ACL occurs in many cases. The most important medial structure is, of course, the superficial MCL, which arises next to the medial epicondyle and attaches in the tibia at 6.2 centimeters below the medial joint line. The deep MCL is seen under the superficial MCL with its meniscal attachments arising and inserting a centimeter above and below the medial joint line. The next important structure is the posterior medial capsule, which includes the posterior oblique ligament and the attachments of the semimembranosus. In a nutshell, grade 1 MCL tears are strains with only pain and valgus stress. Grade 2 tears are partial tears with opening in 30 degrees of flexion with no opening in 0 degrees. Grade 3 tears are complete tears with opening in both 30 degrees and 0 degrees of knee. They are usually associated with concomitant cruciate injuries. Immediate intervention for medial-sided knee injuries are only when you have an open knee dislocation, the presence of neurovascular injury, or when you have an irreducible joint. We all know that the MCL heals very well, hence a stick-down protocol is used. As a rule, conservative treatment of all grade 3 MCL injuries requires a short-term immobilization of the medial ligaments so that they heal well with least elongation or laxity by limiting medial joint opening and external tibial rotation. This is done by placing the knee in a knee brace or even ideally with a tube cast for the medial structures to heal well in the initial period. Repair is done in the subacute period when the tissues are less friable. MCL repair is done when you have a grade 3 mid-substance tear of the MCL, Steiner-like lesions, MCL interposed in the joint, MCL interposed in the medial tibial condyle fractures. Grade 1 and 2 are usually conserved. The first indication, you can see in this image that there is a mid-substance tear of the superficial MCL. Patient had grade 3 opening. Patient also had a concomitant ACL tear. BTB was used for ACL reconstruction. Care is taken not to harvest the hamstrings since they are very important medial stabilizers of the knee. The tone ends of the superficial MCL are identified and an end-to-end repair of the same is done in this fashion. The second indication is a Steiner-like lesion. Steiner lesions of thumb are conditions where the adductor pollicis aponeurosis interposes between the bone and the ulnar collateral ligament, preventing the ulnar collateral ligament to heal to the bone. Similarly, in the knee, the MCL is avulsed off from the tibia and is proximally retracted, and then the MCL falls anterior to the sartorius fascia. Now, the sartorius fascia prevents healing of the superficial MCL to the bone by interposing between them. This diagram shows the correlation between the sartorius fascia, gracilis, and semitendinosus, which are anterior to the superficial MCL. Once the superficial MCL is torn off from its tibial attachment, the retracted superficial MCL falls anterior to these structures, and during repair, these structures should be elevated so that the superficial MCL can be put back into the bone. This can be done on a double row fashion as seen in the first image, or to prevent over constraint of the knee. It can also be done using a single suture anchor in the tibial attachment as shown in the second image. Now, this patient had a grade 3 opening with concomitant ACL and PCL tears. After cruciate reconstruction, a 5 mm metal anchor was placed on the tibial insertion of the superficial MCL after reflecting the PES. And the superficial MCL was reduced back to its tibial attachment, and sutures were passed to the superficial MCL and anchored back to its tibial insertion with minimal varus stress. Now, this is how the immediate post-op looks with reduction in tibial in medial opening, and that's how the post-op X-ray looks. This is a similar case. Patient had grade 3 opening of the knee in the medial compartment. During arthroscopy, you can see the fibers of the superficial MCL. Usually the capsule is also torn in these conditions. After cruciate reconstruction, the PES is elevated, the superficial MCL is brought down to its tibial attachment and anchored with a suture anchor. And the PES and the capsule is repaired after it. The third indication is when you have an MCL interposed in the joint, you will have an X-ray like this with incongruous reduction. And in this case, the femoral attachment of the superficial MCL was avulsed, and the superficial MCL is flipped into the medial compartment over the medial meniscus. Usually during arthroscopy, you can see the medial collateral ligament inside the knee joint. This requires immediate open reduction. Patient usually presents with a puckered sign or a dimple sign with puckering of skin in the medial side of the knee, and the superficial MCL is usually flipped out of the joint and reattached, in this case, to the femoral attachment. Similar flipping of the MCL into the joint can happen from detachment in the tibial side, where it is released and reattached to the tibia. The last indication is when you have an MCL interposed in the medial tibial condyle fractures, such as these. These are high velocity injuries. Patient may usually require an external fixator. And during external fixator and close reduction, the surgeon usually sees that the medial condyle does not align to the shaft, and this is usually because of the interposed MCL. And during surgery, once the MCL is removed from the fracture, they usually heal well. The last indication, the last part of the talk is posterior oblique ligament advancement. After repair of the superficial MCL, if the surgeon finds that the posteromedial capsule is lax, a vertical incision is made over the posterior aspect of the superficial MCL, and a vest over pant fashion imbrication of the posteromedial capsule is done with reefing of the posteromedial capsule over the superficial MCL, as in this case. This covers repair of the medial structures of the knee, and thank you.
So, faculty, any questions? Sundar.
It's just one question. So when you just do all this your MCL,
Are we allowed to ask question now?
How?
Hello?
What's the time cutoff line for do repair?
Can someone hear me?
Then we place the glenoid.
Can you repeat it?
when you repair
The little shoulder, place the glenoid where it lies.
Hello? Can someone hear me?
Yeah, I can hear you, Roshan.
Yeah.
Roshan sir, I can hear you. Please tell me.
Yeah, are we allowed to ask question?
Yes, yes.
Much of background
Yeah.
noise.
So I think there is a lot of noise in background. Yeah. So
I can hear.
Bhupesh, that was a wonderful talk on MCL.
Thank
I
you,
just
sir.
wanted to know from you that whenever you see a grade 3 MCL, because both the videos you have shown, they were lax in extension.
Correct,
In
sir.
those situations, will you like to repair the POL on the at the time of repair, or you like to do a reconstruction for POL?
No, sir. Whenever we are going in the early subacute phase, after the repair of the MCL, if the POL is found to be lax, immediate reefing of the POL is done. If these fail in the later stage, we can always reconstruct. But the order of preference would be first to reattach the MCL proper, deep and superficial, and then reassess the posteromedial capsule. If there is laxity, posteromedial POL advancement procedure is done. If it is not lax, then we will leave it with just MCL repair. In case in later stage there is laxity, it can always be addressed with the reconstruction.
Okay, let me reframe my other question.
Unlike the lateral sides, a need for lateral reconstruction at the later stage is very, very.
So let me ask you another way. What are your indications of not operating MCL injury, grade 3 MCL injury? Do you always, because both the patients were female in your case, do you like to conserve them, or you always operate MCL injuries, grade 3?
Sir, grade 3 indications when there is opening, full opening in extension of this degree, surgical intervention I always do, sir, because most of the time there will be residual laxity. The beauty of the medial side structure is they heal very well. So to go in and aggressively repair, grade 3 gross opening on full extension and is an indication for repair for me, sir.
The question that was asking, probably that time it was noisy, so I could not complete the question. When
Tell
you,
me.
as Dr. Roshan was asking, that when you repair all these grade 3 injuries, medial MCLs, you anything just to protect your repair?
Do you do anything to protect your repair is the question, sir?
Do you reinforce by anything to protect your repair, like your fiber tape or
No,
graft?
sir. I don't do any internal bracing for medial side. Unlike the lateral side, where repair is also added on with the reconstruction in the same sitting, because we know lateral sides don't heal well. Medial side, I usually don't add on any fiber tape or semi-T to protect my repair, sir. Because usually in the subacute phase, the tissues are good. They are not friable. Usually you can get good tissue to be repaired it back into the bone.
Roshan, what's your opinion? I think also I will take opinion of my dear friend Raghu.
I usually never do internal bracing because I don't like the concept of internal bracing. I always believe that normal collagen has to take its own place, and the stability can be achieved given by normal collagen. So I don't believe in internal bracing, and I always like to do the augmentation if the repair is incomplete, like what showed Bhupesh has shown 2 cases. Both the cases were lax in extension. So in my choice would have been MCL repair along with POL repair. In case there is a instability more prominent on extension, I would have added augmentation of POL if required, because 30° they are opening up.
Upesh.
Sir,
Yeah,
Sundar.
Sundar. Upesh, do
Yeah,
you
Sundar,
do
tell
you
me.
decide about your repair or augmentation or reconstruction after finishing your ACL reconstruction, or you decide before your ACL
No,
reconstruction?
sir. Always after the ACL reconstruction, sir. Because always after ACL reconstruction, grade comes down by 1 degree, and then do a reassessment, and then I will do the MCL. Then the grade will come down by another 1 degree. Then, if required, I will look into POL, sir. That is my order of repair. That is what I was trying to say in the last time also.
That's
Always
what,
cruciate first, followed by superficial and deep MCL, followed by POL. That will be the order to.
probably because the cases which you saw preoperatively lax in extension will become all right after doing the ACL reconstruction.
Correct, sir.
So probably many times we may not need to do an augmentation for the POL by the time it becomes stabilized. Even that superficial MCL in 20 to 30 degrees become grade 2 or grade 1. So we may not need to do anything. Again, if it is after doing ACL reconstruction, if you feel that it's a grade 3, then depending upon an extension or flexion, then you do an augmentation or a repair like what Roshan suggested. That's what
Sundar. In fact, half of the world doesn't believe there is an existence of POL. If you go to Japan, Korea, Europe, and South America, they don't reconstruct or repair POL. They always do only superficial MCL. I have been to Japanese knee society and Korean knee society. They don't believe. Even the leading surgeons like Kurosaka, Uchi, and all these top knee surgeons from Japan and Korea, they never do POL reconstruction. They always do something known as the superficial MCL, and they believe that there is only one ligament. As compared to European world, they don't believe in POL. If you go with all these top knee surgeons from Europe, Martin Lind, who popularized the superficial MCL reconstruction with SEMITI, he also doesn't believe, and majority of the European surgeons don't believe in POL. What they do is just a superficial MCL reconstruction. And because I think what point you have said is absolutely right, the extension opening of the knee joint is majorly attributed to the ACL rather than to the POL.
Original POL.
Roshan sir, only Labrat Raplad and India believe in POL, I think.
Yeah, because we are more of Americanized people, we are Americans. Look at surnames, Dr. Wade, Dr. Samantha. So all are American people, Samantha Fox and Matthew Wade.
Samantha Fox.
I believe on POL.
Thanks, Bhupesh. Points well taken from Roshan Sundar. Only after doing the ACL, we have to go that whether the MCL is required. That too, in terminal extension, it is lax. We have to go to some repair. Now, I request Dr. Chirag.
MCL reconstruction.
MCL reconstruction. AV guys, can you start?
We would be speaking on the medial collateral ligament reconstruction. There were various conventional techniques through which the MCL injuries used to be treated in the past, but of late there's been a changing trend in the approach and the management of the MCL injuries, and this is attributed to the better understanding of the anatomy. We now do understand that there's a superficial medial collateral ligament, there's a deep medial collateral ligament, and very critically, we have a critical ligament which forms a component of the MCL is the posterior oblique ligament, which provides stability to the post-medial aspect of the knee joint. How do we reconstruct this? There are various techniques described in the literature to reconstruct the MCL, among which the simplest technique what we follow is the technique by the Chinese who describe the reconstruction of the MCL and the POL using a single SEMITI graft. The first thing what we do is mark out the bony prominences, the joint line, the tibiotubercle, the patella tendon, the patella, and the middle femoral condyle. one would then take a curvilinear incision starting from the medial femoral epicondyle down about 8 to 10 centimeters below the joint line. We then dissect out the skin, the soft tissue, that's the superficial and the deep fascia, and then the sartorial fascia is identified and split to identify the medial collateral ligament. We now identify the medial collateral ligament, the tone portion, and then also identify the POL. It's the next step is to identify the insertion sites of the superficial MCL and the POL, and make your skin, make your bony landmark markings, which is then drilled or pointed out through bead pin, one bead pin at the insertion site of the superficial MCL and another bead pin through the proximal insertion site of the POL. This could be doubly confirmed. The insertion site could be confirmed using the image intensifier. The bead pins are then over drilled with 6 millimeters drill bit, both on the side of the MCL and of the POL, and then the non-absorbable suture materials are then railroaded through these tunnels. One would now have 2 tunnels in the femoral medial femoral condyle, which would act as an insertion site for both the MCL and the POL. The next step is to identify the joint line and mark out a point about 7 to 8 centimeters below the joint line in the medial tibia. This would act like a distal insertion site for the superficial MCL. One would then go ahead and mark the tubercle of the insertion site of the POL. Both of these insertion sites are marked out, and then one would take a ACL jig starting from the insertion site of the superficial MCL and exiting out through the insertion site of the POL. One would take a bead pin and then drill through and through to create a tunnel which would start or which would enter from the superficial MCL site and exit out through the insertion site of the POL. One would then railroad this suture as well. Hence, we have the insertion sites of all the 4 attachments, that is the MCL and of the POL. One would then create a trough just above the insertion of the superficial MCL, so as to create a bleeding surface in the bone, which would help us or aid in the tenodesis of the tendon which one would desire to insert. Now, I always augment my MCL reconstructions with fiber tape. One could start suturing the whip sutures on both the ends of the cemetery tendon, incorporating the fiber tape to provide some additional stability and to avoid stretch out of the graft. Once the graft is prepared, this is then passed from the insertion site of the distal insertion site of the POL, coming out through the distal attachment site of the superficial MCL, and then exiting out proximally. Proximally, these are passed through the tunnels, and then the 2 insertion site, proximal insertion site of the superficial MCL and the POL. Go ahead and fix the proximal attachment site of the POL with the knee in full extension with a little bit of a varus thrust. One would then attach the distal attachment site or re-augment the distal attachment site of the superficial MCL using a bone staple, and then with the knee in 30 degrees of knee flexion with the varus force, one would go ahead and insert the proximal screw of the superficial medial collateral ligament. Hence, one could also use a bone anchor and then doubly secure the graft down to the bone. Hence, we have the reconstructed superficial MCL, which is taught in 30 degrees of knee flexion, and the POL, which is lax in 30 degrees of knee flexion. And as we see from knee flexion, when we extend the knee joint, we then see the POL is much more taut, hence providing stability on the posteromedial aspect of the knee in knee extension. One would then go ahead and suture the opened up sartorial fascia. This would complete our procedure, hence providing a complete repair or reconstruction of the medial collateral ligament. Thank you.
Roshan, any questions? Roshan? Suddenly, sir. Sundarajan? Any questions for
It's a wonderful
MCL
concept demonstrated by Chirag. Chirag, do you do any tibial inside tunnel fixation before you fix the femur and tibia? Because when I saw the video, you fix the femur first and tibia, I mean femur, both screws. Then you come back and fix the superficial MCL with the staple. Before you start fixing the femoral tunnels, do you do interference screw fixation in your tunnel, which you made it for your superficial MCL and POL in the tibia?
So ideally, it's if we are using a 6 mm graft, we would use a 5 mm screw and fix it with the screw, so that both of the ligaments act independently.
Yeah.
But I usually use a single staple at the distal end of the superficial MCL for cost constraint reasons.
Chirag, do you put an anchor to secure a deep MCL to prevent a bursting like action in the tibia?
That was what I did in the last step. The literature of this Chinese technique doesn't describe that. This is an additional step from our side, which we do. About 5 millimeters below the joint line, I just put an anchor and to probably re-augment the deep MCL and to prevent the bursting.
Correct. Thank you.
So, Dr. Chirag, one more thing. So, when you're putting the femoral side, do you have try to take out an isometric points?
Yeah. So isometric points, we all know that superficial MCL is about just above and posterior to the medial epicondyle, and the POL insertion site would be above and below the superficial MCL. So we mark out
Chirag, I feel isometric philosophy is not going to work in MCL side, because MCL is lax in extension and POL is tight in MCL is lax in flexion and POL is tight in extension. So in those situations, isometric points are not going to work because it is completely independent of the range of motion.
Yeah. So what we do is first you put the points of the superficial MCL, put your thread there with the bead pins, and then see the laxity in flexion and extension. Similarly, do it for POL.
So that brings us to the first question by Sundarajan. Do you do femur first fixation or tibia? Because the moment you do a tibial fixation first, I usually use an endo button on that side, so that you can avoid the graft crushing either through the ligament staple or through the interference screw.
Yeah,
Best is to use the button.
To be used.
Yeah. And then you can play with on your femoral side, because femoral side the attachments are very close.
Yeah.
They're very near. So I totally agree with Sundar that you can finish up your tibial work first, and then you can come to the femoral side, so that the center of rotation is very close to the femoral epicondyle.
That's one option.
that is true, Roshan. So I think the POL reconstruction doesn't have any isometry, but you have to check for the superficial MCL isometry on the femoral side. That is my point. Because in flexion, the isometry will change. So in POL, if you reconstruct the POL in extension, when you have a flexion, it will go into lax. It will allow the knee flexion. But if it is not isometry in superficial MCL, definitely it will become very stiff knee.
That means that you're giving more importance for the superficial rather than the POL.
Both are important. In flexion, entire range of flexion, it is superficial MCL is very important. In extension, near extension, it is the deep MCL, not deep MCL. POL is very important. Yeah.
Thanks, Chirag. Evi guys, now you can start Jaya's lecture, PLC reconstruction.
Good afternoon, everyone. I am going to talk on the posterolateral corner reconstruction. The incidence of isolated PLC injuries are very rare. It is around 2% of all injuries. And the incidence of associated injuries with the ACL and PCL disruption are more common, is around 43 to 80%. So whenever you have the ACL and PCL, you need to examine these PLC injuries. Otherwise, you are reconstructed the ACL and PCL goes to failure. The PLC complex main structures are the lateral collateral, popliteofibular ligament, and popliteal. So the main stabilizer for the varus and external rotation, and secondary stabilizer for the posterior tibial translation with the PCL. So mechanism of injury: blow to anteromedial, blow to flex knee, contact to non-contact, hyperextension injuries, external rotation twisting injury, knee dislocation. These are the mechanism of injuries. And associated injury with the PLC. For the PLC injury, when we have a PLC injury, is a common peroneal nerve and vascular injuries. And common peroneal nerve should be documented and should tell the patient beforehand, so that because whenever you are doing surgery, there may be a chance of common peroneal nerve injury iatrogenic. That is a very important thing. And the symptom the patient will have instability, and whenever they have they goes for the staircase or pivoting activities, cutting activity, they will have the pain and gait. When in chronic cases, you will have the varus gait with the hyperextension. So this is a very, very important thing when your patient is coming inside your room. You need to examine the check for the gait of the patient. And the varus stress test at 0 degrees for the LCL, ACL, or PCL injury, at 30 degrees for the identifying the LCL injury, and dial test at 10 degrees of external rotation, more than 10 degrees. At 30 degrees, you think about the PLC. At 30 and 90 degrees, you think about the PLC with the PCL. And external rotation, recurrent deformity, and reverse pivot shift, and postlateral broadhead. These are the things you need to examine when patient is having a PLC injury. And peroneal nerve injury, plain X-ray is very important for the to find out the avulsion injuries. For fibula and the varus valgus stress X-rays at 20 degrees to know the side to side difference. If it is side to side difference at 2.7 to 4 mm, you need to think about the only isolated LCD injury. If it is a more than 4 mm, think about the complete PLC injury. And AP standing varus thrust X-rays for the chronic cases. And bilateral PCL stress X-rays, if it is a 4 to 12 mm, need to think about the PCL, isolated PCL injury, and more than 12 mm, check for the PLC and PCL combined injuries. And MLC is, MRI is a gold standard. You need to check for the coronal view, axial and sagittal view to find out the entire PLC complex. You need to discuss with your radiologist not to skip any component of the PLC injuries. And grading system, Franklin is graded grade 1, grade 2, grade 3, depends on the external rotation and the varus opening. And this is the flow chart to for the treatment. Grade 1, grade 2 isolated injury, you need to go for the non-surgical management. Isolate avulsion injury of grade 2 and high demand patient, primary repair with the augmentation. Grade 2, the combined injury. Grade 3, injuries, in acute injuries, you need to have a primary repair with the augmentation. In chronic cases, more than 3 weeks, no alignment problem, you need to have only rotational deformity, anatomical PFL reconstruction, and varus deformity, anatomical LCL reconstruction. In combined rotational and varus deformity, you need to reconstruct all structures like LCL and PFL reconstruction. So if it is having a malalignment in chronic cases, you need to find out the full-length X-ray and plan for the osteotomy without reconstructions. And a non-operative management for the grade 1 and the mid-substance grade 2 isolated injuries, need to keep the knee in extension, complete extension with the blades. LCL repair, indications is isolated acute grade 2 PLC avulsions, but and mid substance repair case you can repair, but there is a 40% of failure. So whenever you are doing a LCL repair, you need to have combined reconstruction procedure for these patients. So there are Larson, modified Larsons, loop techniques. These are the initially described for the isolated LCL reconstructions, and later anatomically based, biomechanically validated post-lateral reconstruction is developed by the Laprade. This is the gold standard now, and there are two components. One is the one graft is for the LCL and the PFL, and another one is for the popliteus tendon. So the anatomical footprint is very important for the LCL and popliteus, and the LCL and the popliteofibular and popliteus. There will be two year one tunnel in the tibia, around 1 centimeter down, and one is for the on the fibular, and another two tunnels for on the femur. And later in 2008, this is anatomical reconstruction again with the biceps tenodesis along with the components with the gracilis and the semi tendinosis. And similar technique I developed in 2015. We Laprades technique, but with only one tendon, I fulfilling the entire strategic complex. I presented this my work in 2015 in IAS conference, and this is a preoperative dial test. And this is harvesting the hamstring. And I take 7 mm, minimum of 7 mm. This is a curvilinear epicondyl to the fibular head, and most important has to be dissected from proximal to the distal. So this should not be resutured and protect the common peroneal throughout your entire procedure. And important thing is split the ATB proximally and identify the anatomical footprints on the femoral side, that is around 3.1 mm posterior and 1.4 mm proximal to the lateral epicondyle. This is the anatomical footprint. And then in 70 degrees of flexion, 18.5 mm anterior to this footprint is the popliteus insertion. And then you take the loop from the popliteus hiatus and split ITB and the posterior to the biceps tendon, and then you make the tunnel on the again specific points like 8.2 mm posterior to the articular margin and 3 centimeter distal to the tip of the fibular striate, and then you secure with the thread, and then the tibial socket. This is the difference in the Laprade technique. I use the flip cutter here 1 centimeter below, and instead of doing the tunnel, I'm using the flip cutter and making the socket. So this is the socket securing this thread, and then this is a fibular drilling on the femur, and then femoral tunnel drilling, and then securing with the threads. Fall tunnels, and then passage of the graft through the. First, I'm introducing this graft, bit of the graft through the tibia, tibial socket. That is this adjustable loop is coming out, and then the graft for the LCL. One end should go for the LCL through the fibula, and that is the opening, and then the graft for the popliteus. So under the popliteus hiatus, and then the graft. So each graft tension. So an important thing is check flip, and then so you can put the screws. Either biodegradable or metal screws. And the final tensioning advantage of my similar technique for the Laprades is you can do end adjustment with the tensioning of the button. And what are the sequence of fixation? The PCL is the first one to be fixed, that at 90 degrees of flexion, ACL is around near the full extension, the PLC should be tensioned at last. So when you tension initially, there will be increased internal rotation. So the FCL should be tension and fixed at the 30 degrees of flexion, and the PLC other structures remain remaining structures has to be fixed at 60 degrees of flexion. So this is a post-op dial test. Surgery. Yeah. So rehabilitation is non-weight bearing for 6 weeks, and range of motion protocols immobilized for 2 weeks, then begin motion and return to activities like 6 to 9 months for sports. And these are the comparative studies between the sling procedure and anatomical reconstruction. You can see the external rotation and varus deficit is more with the sling type of procedure than the anatomical reconstruction procedures. Thank you very much.
Yeah. Faculty, questions are.
Yeah.
Sundar.
Yeah, my question is like your technique. I mean, do you prefer for all your cases, or you isolate cases like only LCL injury, or you do all, I mean, only for LCL with popliteus?
So this technique is fulfilling the fulfilling all the components of the PLC. So this technique is developed in 2015, and it is similar to Laplace's technique. Okay, and there he is using 2 grafts. Here I'm using only 1 graft, minimum of 7 mm.
The many cases we may not have both components, isn't it? So sometimes
Yes.
we have only lateral LCL problem, or sometimes we have both issues.
Yeah, I do depends on the patient's injury. If it is a LCL, isolated LCL, I will go for the Larson's technique. Okay, and popliteus is stretched out, I will go for the modified Larson's technique. Yeah. So if it is complete 3 components are torn, I will go for the Laplace technique, and sometimes I use this technique also. Yeah.
Yeah.
Yeah. Tell me,
Can
question.
you hear me?
Yes, question.
Yeah, Jaiprasad.
Yeah.
I just wanted to ask you about the technique what we use. The assessment of the posterolateral complex injury.
Yeah.
Your decision making, whether to do PLC or do only popliteus or only LCL, and how to diagnose that, because clinically it's very difficult to diagnose which component is gone and what component is remaining, especially when you have a combined injuries. So any tips to diagnose those components of PLC injury isolated, like popliteus, LCL?
Yeah, popliteus, isolated popliteus, more of popliteus is more of it is a component to restrains the posterior translation and the component which restrains the rotational. So when you have PCL is normal, and your posterior drawer like more than 12 mm, you have to think about the PCL and PLC. And if it is less than 12 mm, you need to think about the popliteus tendon. And because this is only single component which will give a posterior translation resistance. So if it is a varus is more, so you think about the lateral collateral ligament, and if the rotation is more than 10 degrees, okay, 10 degrees rotation more compared to the other side, you think about the popliteofibular ligament. That's how I will make the decision. It's like X-rays, clinical examination, X-rays, MRI. Mainly intraoperatively also at the end, I will see my popliteus tendon. If it is have a doubt about the PCL laxity or the popliteus, yeah, there I will go for the arthroscopy and decide.
Thanks, Jayaprakash. Now I am waiting for Sundar Rajan talk on management of multi-ligament injury. Sundar, heavy guys, Dr. Sundar Rajan talk.
Multi-ligament injuries. In knee dislocations, each injury is different, and complex anatomy makes difficult in managing these injuries, and it needs more arthroscopic expertise and experience coming to the management of knee dislocations. What I mean by complex anatomy, I think it's very important to know the anatomical attachments in the femoral side and tibial side, like superficial MCL, posterior oblique ligament on the medial side, where you need to do a repair or reconstructions. In the lateral side, you should know about the fibular collateral ligament, popliteus tendon, and the popliteofibular ligament, which are the important stabilizers for the lateral side and also for the rotations. When it comes to the sense classification, what we are talking about, the more common injuries are KD3 medial M and KD3L. Of course, when you have a KD4 and KD5, still more difficult to manage these cases. Coming to the case example, this is a 22-year-old male patient who had a history of injury to the right knee following road traffic accident, presented with a painful swollen knee and couldn't be able to walk. This is the X-ray. When you see an X-ray in the casualty like this, it is important that you should understand this could be a spontaneously reduced knee dislocation. So we cannot just think that knee is normal. So also always you should look for asymmetry in the joint space. Any minor subluxation or any avulsion fractures also indicates there could be a dislocated knee. So how to proceed in these cases? No plaster in any knee dislocation cases or any knee injury cases, which is not necessary. Even in acutely injured knee with a swollen knee, it is important that we should do a clinical examination. Gentle clinical examination will show how much medial lateral instability, how much Lachman is positive, whether it's stable or unstable, which we can predict the nature of injury, whether it's a low valence injury or a high valence injury. Of course, we proceed with the MRI to know the seriousness of the ligament injuries to proceed further. Of course, when you have a frank dislocation without reduction, if the patient present to the casualty, make sure that you are not putting in a plaster. You can see this X-ray, they put in a plaster. That should not be done, because whenever you see a dislocated knee, it is important that you reduce in casualty or take to the theater and reduce it. Then we can proceed for further investigations. So we should suspect vascular injury whenever in multi-ligament injuries, whenever there is a decrease in pedal pulses, in the lower extremity color or the temperature and the physical examination, or expanding hematoma in the popliteal fossa indicates it's a vascular injury. These patients require CT or MRI angio for the vascular repair. By early diagnosis of arterial damage is very, very important, because if we delay more than 6 hours, then chance of amputation is around 94%. So whenever you have a vascular injury after the knee dislocation or a reduced knee dislocation, it is very important you feel for the pulses. If they are asymmetric or if the ABI is less than 0.9, then patient needs arteriogram. Or the distal pulses are absent or other signs of vascular injury clinically, if you strongly believe, then you can go for the patient can go directly to the operating room even without CT angio. Other than vascular injury, there are some other injury needs immediate interventions like open dislocations or irreducible dislocations. Otherwise, all other injuries can wait for 2 to 3 weeks time. This is an example of one patient where 36 years old. You see the hematoma. There is a redness over the medial sided injury. You see the X-ray very carefully. There is a subluxed knee opening on the medial side too. So when you see an MRI, you can see this patient had got a dislocated knee and got reduced. MCL got entrapped inside the joint. These are one of the indications where you can go ahead and do the open reduction. Make sure that you reduce that dislocation after removing the MCL, which was entrapped into the joint, and we can do a repair, because just that femoral avulsion, it can be repaired easily. Then we can delay the cruciate, or you can do it the same stage depending upon your skills. So what to do in the first 2 weeks, or in other cases, first 2 weeks, immediate when the patient presents on day 1, you put them on immediate immobilizer and make sure that you are giving enough rest to the knee joint to become quiet. Even it's an bony avulsion injury, there is no need of surgery on day one. Once the knee swelling has come down, the second week or third week, you can put on a hinge knee brace, do the knee mobilization. If the knee mobilization gets more than 90 degrees, then we can think about surgery. Can we do a conservative treatment for multi-ligament injuries? Of course, in low energy injuries like in the KD, especially in the middle and old age patients, still these patients, this can be treated conservatively, but still they can give a very good result. If you do a proper immobilizer with like posterior supporting brace, then mobilize after 6 weeks time, many patients, the PCL heals very well, then they can have a good stability. When it comes to the surgical management in younger patients, unstable injuries, in the single stage also can be done, or it can be done in 2 stages, depending upon the velocity of the injuries. When you do the staged approach, always is good if you're a beginner. If you think that you're going to take long time, staged approach is good. It also reduces the arthropfibrosis. However, it takes 2 to 4 months between the surgeries, and we need a 2 rehabilitation program. But when we do the single stage, of course, the minimal morbidity, the cost is reduced, and no need of rehabilitation twice. However, we have to take it as a pinch of salt, and unless you have a good experience, better to do in 2 stages procedures. When it comes to the sequence of ligament reconstruction single stage, medial and lateral sided injury should be addressed. Bony and soft tissue avulsions can be repaired. When it is a mid-substance tear, it requires an augmentation with the repair along with the grafts, or we can do an internal bracing along with the repair. Cruciates, PCL is reconstructed first, and if you have expertise, you can do an ACL also, or ACL can wait. Sometimes these patients may not require ACL reconstruction also when you do it in a single stage. When you do a 2 stage, you address the collaterals first, and you support with the posterior supporting brace, leave it for the second stage to do a posterior cruciate ligament with or without anterior cruciate ligament reconstruction. This is an example of 25-year-old male patient presented with a two-wheeler accident, and he had an IL bandage for 10 days. This was the X-ray. You can see the still subluxed knee and anteriorly translated. This patient got a ACL and PCL tear, LCL complete tear, and flipped lateral meniscus. And also there is a displaced medial meniscus. These are the very complex injury, and there are KD4. It is very difficult to do in a single stage. These patients can be reduced first, then you do the reduction of the medial meniscus and repair it, and also then you do an open LCL and popliteal repair with the suture anchor, and they were immobilized. Once you stabilize the collaterals and the meniscus, the knee was stable, then it was immobilized for 4 weeks time, 6 weeks time, then mobilized. Then patient proceeded the 8 weeks with the posterior sag. You can see by the time the meniscus is healing very well, then this patient end up with having both the PCL and the ACL reconstruction. You can see that is a completely stable knee. There's 2 stages because it's a KD4 high velocity injury. There's another patient who had an ACL and PCL MCL injury with the medial meniscus and meniscocapsular separations. Here again, these patients, medial meniscus separations from a capsular ligament can be repaired first. We should repair from a deeper layer to the superficial layer. You do the meniscus repair, then you do the capsular repair. For the mid-substance tear, we augmented with the graft, semitendinosus graft here it was used to do the augmentation. And this was the post-op X-ray, completely stable knee after doing the meniscus repair and the medial collateral ligament. And you can see that complete stability once you do the medial sided repair. When you have a mid-substance tear, always do a augmentation, or we can do a reconstruction, or you can also add an internal bracing in a few cases. So better to do a repair along with augmentation in mid-substance tear, because only repair, the chance of failure is around more than 40%. To conclude, be suspicious about dislocations in all knee injuries. Paramount importance is for neurovascular examination. Assess the stability. Medial and lateral sided avulsions can be repaired, and mid-substance tear requires repair, augmentation, or internal bracing. When you want to do it in a single stage, collaterals are addressed first, then posterior cruciate ligament are addressed at the same stage, with or without anterior cruciate ligament. When you want to do in 2 stages, collaterals are addressed first stage. Make sure that you are stabilizing the PCL with the posterior supporting brace, and in the second stage, we can do a cruciate ligament reconstruction. Thank you very much.
Rajan?
Yeah.
The sequence of your ligament reconstruction in four ligaments
There
stage.
is a single stage. What you're asking about a single stage?
Yeah, single stage.
Yeah. So when we do on a single stage, usually I try to do the if the knee is very stable, I try to make the tunnels for the PCLs and make the tunnel inside. I make the graft, fix the femoral side, and leave the tibial side. Then I go to the collaterals. Then collaterals I open up and do the all the procedure. Then when you do the fixation, I will fix the PCL first so that the knee gets stabilized. If it is not if it is not a unstable joint. If it is an unstable joint, then I fix the collaterals first. Then make sure that medial laterally doesn't move. Then I fix the PCL. So depending upon the very stable or unstable, then I change the fixations.
Sundar?
Yes, Roshan.
Hello?
Yes, Roshan.
Yeah, Sundar, that was a wonderful presentation. The only thing which I'd like to add is whenever we plan for a fixation, on coming back to Jay's question, I believe that the central pivot, a central fixation is PCL.
Yeah.
So the moment you fix PCL, many things will fall in picture because even if you do
Hello,
all
evening
the
guys.
collaterals, unless you have a normal alignment of PCL, your collaterals are not going to be neutralized. So I believe that PCL fixation is first. Most important issue, Sundar, is the tunnel convergence. Whenever you do a lot of tunnels on the medial as well as the femoral condyle, lateral femoral condyle. So how do you avoid that tunnel convergence? Because that is the critical issue. Because when you want to do a Laprat type of PLC reconstruction along with the ACL, there are three tunnels on the lateral femoral condyle. And when you want to do a posterior complex or medial complex reconstruction with PCL, there are again three tunnels on the medial femoral condyle. So total 6 tunnels on the femur. So how do you avoid that convergence?
Yeah, medial side I try to avoid whenever I try to do MCL reconstruction. If I avoid 2 tunnels, I try to make it in a single tunnel in the medial side, and I do a PCL reconstruction. Most often doesn't come in a way because your PCL, when you do an only single bundle PCL, also I do only single bundle. So when you do only single bundle technique, I don't think there is any major issue between your MCL reconstruction and your PCL reconstruction. Only problem comes to the lateral side when you do try to do an ACL and do a Laprada, then there is a problem. Then probably here ACL I try to do an outside in techniques to make sure that it doesn't converge with the your femoral tunnels. So on the femoral tunnel of PLC. And make sure, because you are making anyway, you are making an anatomical ACL reconstruction, your tunnel is bit low. So make sure that when you make that lateral tunnels on the femoral side for the PLC, make sure that your trajectory goes more upwards and more proximally so that you don't cross the ACL tunnel.
Second question was related to vascular injuries. When you see the knee dislocation along with vascular injury, the patient has undergone the vascular repair, and patient is back to surgery for the reconstruction of the ligament. So what precautions you like to take? Because now we don't know what is the course of neurovascular bundle, how close they are with the proximal tibia, and in those situations, any special tips on that?
Usually here, I mean, I think the 6 weeks, the vascular surgeon won't allow us to touch. And we keep in immobilizer or we usually keep an external fixator for at least 4 to 6 weeks time. Then we start moving the knee. And a few cases can become stiff also, especially if it is in a fracture dislocation, then the knee becomes stiff. And most often I don't need to do a PCL reconstruction because they may not get a full range. By the time we get the 100 degree, 110 degrees, the knee becomes stiff. So these patients, I may not do anything. But when you have a stable, grade 3 or grade 4 dislocations, then they come back when they have a posterior sag. So make sure that you don't wait for too long time. So we make that supervised physiotherapy and make sure that we get back the movements of more than 90 degrees or 100 degrees within the 8 weeks to 10 weeks time. Because if it goes beyond that, then chance of getting a persistent, your fixed posterior subluxation is very high, because very difficult to maintain without, especially in the vascular repair, it's very difficult to maintain the knee without going posterior sag. So you try to intervene as early as possible. Of course, when you do a PCL, of course, when you do a vascular repair, the chance of adhesions between the posterior tibia and this is very, very high. Of course, we have to be very, very meticulous and make sure that I elevate it with small elevators like what you use for the shoulder arthroscopy. Very carefully, meticulously, you have to separate the posterior capsule from the posterior tibia.
Okay, thanks, Sundar. Points are taken regarding the arthrophyrosis to do it all at one stage and using the outside-in technique when you are doing these multi-ligament injuries. And now I request AV guys to start the Dr. Sachin Tapasi's lecture on ramp lesions.
Looks like Sachin is playing somewhere.
Hello, everyone. My name is Dr. Sachin Tapasvi, and I've been asked to speak on posterior hidden lesions of the knee. Thank you very much for having me over to participate as faculty for this virtual OSS Con November 2020. So when we discuss the posterior side of the knee and we look at the hidden lesions, we look at lesions to the posterior root of the medial meniscus, tears of the meniscocapsular and the meniscosynovial junction of the medial meniscus, so-called ramp lesions, and of course, tears of the posterior root of the lateral meniscus as well. The roots are very important because they help attach the meniscus to the tibia. They also help convert the compressive axial forces to circumferential hoop stresses, which is essentially very important. When you have a root tear, there is increased contact pressure across the tibiofemoral joint, and these forces mimic that of a knee which has had a complete meniscectomy, which is why the roots are very important, and you need to reconstruct and repair these roots as soon as possible when you recognize that you have a root tear that needs to be repaired. Medial meniscus root tears usually are seen more in women than in men. They typically occur beyond the 5th decade of life, and females, especially with a high BMI, are more prone for the same. They will usually have an innocuous injury in which they get off a low chair or a low stool, or they step on a high surface, and this causes the root to tear. Many times they will experience a sudden click and a plop, which is associated with severe pain and delayed swelling. Clinically, the presence of posterior medial joint line tenderness is quite classic, and many times we have shown that a positive Pius test will be associated with a posterior medial meniscus root tear. We published on the same as well, showing a high degree of sensitivity and correlation with a positive Pius test and a medial meniscus root tear. On the other hand, lateral meniscus root tears are seen more in the 3rd decade and are associated more with men rather than women, and are associated with an ACL rupture with a high-grade pivot shift. This particular table shows the high degree association of a lateral meniscus posterior root tear with that of an ACL tear, and that of a medial meniscus posterior root tear with grade 2 chondral lesions of the medial tibiofemoral component, both of these being statistically significant. Medial meniscus root tears are classified into 5 grades depending upon the type of tear pattern that we have. The type 2, which is the complete tear, is the more common tear that we need to sort of pick up and we end up repairing. What is important to understand is that if this tear crosses beyond 6 millimeters from its attachment, it should be considered as a radial tear, and the treatment of a radial tear vastly differs from that of a root avulsion or a root tear of the medial meniscus. On the other hand, if you look at lateral meniscus root tears, they essentially follow the same classification pattern as that of a medial tear. But what is important is to recognize this variant in which you have a prominent posterior meniscofemoral ligament, and this remains intact and the lateral meniscus root tears off. So for me, in my clinical practice, I think type 4s and the variant in which the the posterior MFL ligament is intact becomes more predominant. MRIs are pretty useful when diagnosing medial meniscus root tears, but MRIs do not have a huge predictive value for diagnosing lateral root tears. Lateral root tears are better picked up with an arthroscopy, whereas medial meniscus posterior root tears are picked up very well with MRI scans. And this is the main point that we need to understand. So when you're doing an MRI scan for a posterior meniscus root tear, what do you need to understand? If you have a posterior root tear of the medial meniscus, you will see a ghost sign on your sagittal view where you cannot see the posterior root or the posterior meniscus. Instead, you see a ghost shadow in that place. When you look at axial sections, you can see the complete tear properly, which is called as the cleft sign. And on the coronal images, you want to look for the degree of extrusion, and all of these become very important on both the sagittal, axial, as well as the coronal sections. Alignment is important, and hence plane X-rays are really important when we're looking at root tears, especially on the medial side. Here is one such example of this lady who shows that the joint space is pretty okay, if you ask me to sort of say so. But when you do a long leg scanogram film, you can see that the weight-bearing line passes almost 80 to 90% away from the medial or the midline of the knee joint, and definitely this knee requires more than just a root tear, which will fail if you repair it. This requires osteotomy as well. So my indications for repairing a root, especially on the medial side, are those who have symptoms and are usually less than 60 years of age. You need to realize and understand that the arthritis should be limited to KL grade 1 or grade 2 maximally. You need to have a neutral, or if it is in varus, you need to correct it with an osteotomy at the same time. You need to have healthy meniscal tissue. Of course, you can't expect it to be bang normal like someone who's about 25 to 30 years old, but you need to have good, healthy meniscus tissue, which will hold your sutures, and that becomes really important. The tear should also be reducible to the anatomic location, because if you do a non-anatomical root repair, it will not serve the purpose. And that's why it's really important to release the posterior capsular attachment of the medial meniscus to enable it to get back to its correct attachment. So here's the same patient. You can see that this lady had varus alignment, and she required a root repair, which was combined with a high tibial osteotomy to bring back her alignment to neutral, which is important if you want to have a good outcome. How do you repair it? Well, first you probe it. You prepare the bed by using a special ring curette, and then you also release the tissue along the posterior attachment. Put in stitches, which are usually tapes. I prefer to use at least about 2 to 3 tapes, and these tapes will allow us to bring back the root to its native attachment. It's important to look and understand that you need to cover the tibia. And as what you see here, this is the tibia that is uncovered because of the extrusion. And once we add in the third tape, you can see that the whole, and complete the release, the whole tibia can be reduced properly and can be covered with the meniscus properly, as we have shown in this particular clinical example. So that's what you want to see at the end of the procedure. You want to see that the whole tibia, which is uncovered, as you see here, is now reduced. And sometimes we do add an extrusion reduction stitch to help enable the same. Where should I put in my sutures? And that's a very good study which has been done by James Robinson. And the position 4, 7, and 9, which have been elicited here, have the highest load to failure, which are the position where you want to take your bites in, which is what we want to recreate when we're doing a root repair. Post-operatively, I would allow them flexion to 90 degrees for the first 3 weeks, followed by full range of motion. I would ask them to do non-weight bearing for 3 weeks, followed by 50% weight bearing for the next 3 weeks, followed by full weight bearing. I brace them in a long knee extension brace, especially at night, to prevent a flexion contracture for the first 3 weeks, and then put them on a medial offloader support for the next 3 months till such time that the whole root heals. The lateral meniscus root tear is associated usually with what is called as the Forkel's quartet, in which we have an ACL tear, you have a tear of the posterior root of the lateral meniscus, you may have a posterolateral rim fracture of the tibia, and usually end up having an anterolateral compression fracture of the lateral femoral condyle, the so-called divot or the impression fracture that we see quite commonly, and these are usually associated with high-grade pivot shift. This is a good paper that was published in Kesta, in which they did demonstrate that if you have to have a high-grade pivot shift, then the lateral meniscus is a very important secondary stabilizer to control rotatory forces. And if you were to have a tear on the lateral side, you need to probe and look for a lateral tear of a radial tear of the lateral meniscus, or you should be looking at actively for a posterior root tear of the lateral meniscus, or you could be having bucket handle tear of the lateral meniscus. So whenever you see someone who has a high-grade pivot shift, always suspect a root tear of the lateral meniscus with or without its variations. When you're drilling a lateral tibial root, it's important to avoid coalescence with the ACL tunnel, and we encourage drilling the lateral root tunnel in a figure of 4 position, which allows us to avoid any form of conflict. The lateral root you should be able to put it back into its socket, and this is demonstration intraoperatively of one such lateral meniscus root tear in which we're able to restore the biomechanics completely back to normal. So the meniscus roots provide the only bony anchorage points, and it is important to understand the root anatomy, which is absolutely critical. You have to do anatomical repair, and if you do not repair them, or if you do a non-anatomic repair, please be convinced that you are more likely to have progression of osteoarthritis and progression of disease. Ramp lesions essentially are tears of either the meniscocapsular or the meniscosynovial junction. These have a varied incidence depending upon when you're doing an arthroscopy. If you do an arthroscopy very early after an ACL tear, you may find the incidence to be as high as 40%. But realistically, when you scope these patients maybe 2-3 months down the track, you would find that the incidence is roughly about 9 to 10%, which is what I see in my clinical practice as well. There are certain risk factors which are important. The first of them, as I said, is that if you have early injury or late injury, but if you have a high slope, then you're more likely to have a ramp lesion. How does it occur? There are 2 or 3 ways which are responsible for a ramp tear. First is that if you have what is called as an overload theory, in which when you tear or when you translate, the medial structures give way and cause a ramp lesion. Or the second theory is that when you have a forceful contraction of the semimembranosus, you may land up with a ramp lesion. So these are 2 mechanisms which may be responsible for leading to a ramp tear. They are important because of this paper that was published about 5 years ago in AGSN. On the left, you can see that when you have an intact ACL and you end up having, when you have an intact ACL and when you end up doing an ACL and a meniscus repair, you restore the stability back to normal at varied degrees of knee flexion angles. But when you do not do the repair, or when you do the meniscus repair in rotation as well, you will see that rotationally it becomes stable as well. So what is important is that if you fail to repair the meniscocapsular tear, then you are more likely to fail both in anterior translation as well as in external rotation, which is important to understand that ramp lesions are also important for controlling rotational instability. MRIs probably are not great to diagnose these ramp lesions, but definitely if you pick up these secondary signs in which you see a bone bruise on the posterior medial side, or you see this little cleft, then that should bring your attention towards the presence of a ramp tear, which is what I use in my clinical practice. You need to view them properly, and I encourage all of you to view them through the transcondylar portal. So when you look at these tears through between the ACL and the PCL in this particular fashion, you get a bird's eye view, and then you can see the ramp lesion really nicely, which helps you achieve a good clinical diagnosis. So how do you treat them? You start off by creating a posterior medial portal. You probe the tear, you look at the extent, Then you want to rasp and freshen the edges of the tear. Once you've done that, you want to come in with a curved suture passing device such as the AccuPass or the suture lasso or any such commercially available device. I do not have disclosures on the same. And then you take a bite both through the meniscocapsular junction across the medial meniscus, and then you essentially use your suture settling techniques, which you are very well versed by doing shoulder surgery. You can create either two portals on the medial side, a high and a low posteromedial portal, and use one for suture shuttling and the other one for suture passage. And by virtue of the same, you can then pass your sutures and then tie knots effectively. I prefer to start towards the midline and then work myself out medially. That just helps me sort of overlap any knots as I go in that particular direction. So maintaining and avoiding any form of soft tissue suture bridge is very important. You can use cannulas as well, but I find that especially in smaller Indian knees, I find that cannulas tend to be a bit obtrusive and do not allow me the freedom to sort of work around very freely. Of course, that's personal preference, but you're free to use whatever technique you wish to use. Just make sure that you avoid using any form, you avoid doing any suture bridges, because then you'll end up getting awfully frustrated. Usually about 2 or 3 sutures are required, which help us achieve good firm stability. And then this is what you should be achieving at the end of your repair, where you have a very strong, secure repair, which allows you to then mobilize your patients effectively. So you've put in your first suture, then you come in with your second suture. Again, it's the same technique that you want to repeat all over again. You want to pass your suture, railroad it, bring it across, avoid any suture bridge, and put down your sliding locking knot, which will then help you achieve a good, strong, stable repair. So that's how you can repair these ramp lesions, which by far is the most effective way to do them. To conclude about ramp lesions, you require a high index of suspicion, especially those knees which have a high grade pivot shift. I recommend that you do posterior viewing and posterior probing. You can use all inside suture devices or the suture settling techniques that I just showed, and it's important to allow them to do protected weight bearing. So I thank you to give me this opportunity to share my views on posterior hidden lesions of the knee joint, and thank you for listening.
Sachin.
Yes, sir.
One question regarding your sequence of root tears, middle meniscus root tear.
Yes.
If you want to, you said centralization suture, you want to do centralization first, or you want to fix the root first? Means how you decide?
So centralization, I don't think we have the correct word out yet, whether it is really required or not. What is most critical is to release the tissue or the meniscocapsular junction, which is posterior to the posterior third of the medial meniscus. And by that, we can actually reduce the whole root back into its place, and that usually suffices. In very unusual situations or occasionally, would I then go ahead and do a centralization suture, which I add later if I'm still not happy with the coverage of my tibia. So my prime aim is to get the coverage of my tibia with the root by doing a release posteriorly, reducing it back, and if still there is uncoverage, or if some part of the tibia is not really covered, then only would I add a centralization suture.
Faculties, can I ask questions?
Roshan?
Oh, can I ask a question?
Yeah, sure. I can ask.
Sachin, good evening. Rajkumar.
Good evening. Yes, sir.
How are you, sir? Okay, my first question for you would be on the vascularity of the meniscus itself. The root tear generally, you said I would like to release posteriorly when they are little contracted.
Yes.
By anatomy itself, medial meniscus has got poor vascularity compared to the lateral meniscus. Little fibrous tissue that it gets adhesions with If we go on releasing and then try to bring it back and put it to where it belongs, does it hamper the quality of the repair is my doubt that I would like to discuss with you now. That is my first question.
Thank you, Dr. Rajkumar. Yes.
Should I ask the second now, or would you be happy to answer and
No,
then I ask the second question?
I'll just answer this one first. So I think that's a great question, and even I had that doubt. But I think if you look at basic anatomical studies, what we do understand is that majority of the vascularity comes from the inferior aspect, and what we're releasing is the superior aspect. So we release the superior side, we're keeping the inferior side intact. And for that very reason, one of the other doubts that I had was that am I creating a problem by creating an artificial ramp lesion and causing instability in the knee? And again, the answer goes back to the same thing, that we're keeping the inferior meniscotibial ligament intact by not releasing that completely. And that is why we don't add to any additional instability. And that is where majority of the blood supply is coming in. So I think we don't compromise the vascularity of an already compromised meniscus root.
Now in a meniscus root, there are two halves. One is the one which is very close to the root, and the another half is closer to the MCL and that side, the two parts. So do you always take any sutures on the part that is left at the root, or you just repair the main meniscus to the root?
So that depends upon, the type of tear that we have. And in the type 2, usually the one that is there is that there is about a 2 millimeter cuff of tissue, which is left attached to the remnant of the so-called root that we have. So this remnant which is there does not have enough strength. And if you start repairing side to side in these situations, you may start putting your sutures within the PCL actually. So what I do is that if there is a tear which is beyond 6 millimeters, then I consider it to be a radial tear, and then I repair it as if I'm doing a radial tear repair. And of course, these have poorer prognosis. Those which are within 6 millimeters from the anatomic insertion of the root, I will try and release them and bring them back to as close as the root as possible. I do not want to accept a non-anatomic repair which is further away than 4 millimeters from the proposed location, because that would result in a poorer biomechanical construct.
One last question.
Yes.
When do you actually do HTO with root repairs? Is it in all cases, or only where the alignment changes, or there is some other indication apart from the MRI that says it is extruded more than 3 millimeters, something like that?
So for isolated extrusion in the presence of neutral alignment, no osteotomy, that is very clear. I would do an osteotomy when there are KL grade 1, 2 changes. I will not do any root repair for KL grade 3 or grade 4. So KL grade 1 or grade 2 with a non-neutral alignment is who gets an osteotomy along with the root repair.
What is the cutoff degrees of errors, Sachin, when you do an osteotomy?
So if I find that my weight bearing line is medial to the downslope of the medial tibial spine, then I would do an osteotomy. If it is within the apex of the medial tibial spine and up to the slope or the downslope of the medial tibial spine, and that means about a weight bearing angle shift of about 5% to 10%, I would take it, provided the KL grade or the chondral changes are grade 1 or 2. If there are grade 3 changes, or if on the MR scan you see a focal chondral defect on the MFC and there is a weight bearing line shift of even 10%, then I would add a small correction. And these small bony corrections, I think, are extremely important, because that is a much more powerful tool than your root repair, which allows you to restore and preserve your knee.
Sachin?
Yes.
Sachin, yeah.
Yes,
This
sir.
question is regarding the explosive pivot shift test. So
Yes.
young patient, high-end athlete who is having a explosive pivot shift, ACL with the ramp.
Okay.
So how do you go for this case? Like after a ramp repair, do you examine again for the ALL reconstruction, uh, or you will do ACL, ramp, and ALL?
Okay, so that's a great question. When you have a ramp lesion or a lateral meniscus posterior root tear with an explosive grade 3 pivot, then only restoration of the ACL and repair of the ramp or the lateral meniscus posterior root is not enough in my opinion. What has happened is that the force of the injury is so severe that along with tearing off the ACL, then you would get a tear of the ramp. The force continues to injure the anterolateral complex as well. And a young patient who is engaged in contact sport or even weekend sport for that matter with an explosive grade 3 pivot, I would always add a procedure on the lateral side, whether it be ALL or an LET, depending upon what your philosophy is, to help counteract the same.
Sachin.
Yes, sir.
Sachin, Roshan.
Yes, sir. Yes, sir.
Can I ask you a question related to
Yes, sir.
long years of your knee practice? Because I remember you started practice way back in 98 or 96 rather. So in those days, the roots were not repaired, Sachin. And you must have done a lot of ACL reconstruction during that time. So any of your patient has come back for root related or ramp related problems in spite of doing a very good ACL reconstruction? Because sometimes I feel there are a lot of market pressures which are pushing us a surgery beyond point. So
Yes.
everybody spoke about roots, and they see you, but you can't miss them, or you miss them, they see you. But what happens when you have seen it and you have missed it? And a person like you who has got vast experience of knee surgeries can enlighten on that fact. What happens to those patients which are missed?
Yeah, so that's a great question, Roshan. And I think, yes, I have missed a lot of them. I have seen them, but I didn't know how to classify them, to be very honest. I have seen several of these lateral roots where I saw a prominent posterior meniscofemoral ligament, but probably I just didn't know what was to be done with them at that time. Have I seen them back? Yes, I've seen them back. I've seen them back because they come with an ACL reconstruction failure. You have an ACL re-tear, and in them, I have revised the ACL and repaired the root which has happened. As regards with the ramp lesions, I have not done a ramp. I have done probably a ramp repair in 1 or 2 revisions, but those were revisions that came back in about a year or two. As regards your query about market forces driving us to do more root repairs and ramp repairs, that cannot be completely, kept aside, and that cannot be ignored. But I think when we have good biomechanical data now to show that the posterior meniscocapsular junction is important to restore rotational stability in the knee joint, we have good information now which says that if you leave behind a knee that is unstable in rotation, your ACL can fail. We have good data that shows that when you restore the lateral meniscus root, the the rotational abnormal forces or translation decreases. I don't see much. I don't have much hesitation in utilizing all the good information that we have to counteract the same. Who knows, maybe in another decade from now, we may be looking and doing some other new procedure on the knee joint. And the reason is that no matter what you do, about 10% of your ACLs in the younger population will fail. They will come back with the re-tear. And many times you are aware that you've done the best job possible for that particular person, but still one is clueless as to why that has failed. And probably these could be the reasons why our ACL failed after doing such a good ACL reconstruction.
Yes, yes, Sachin, I completely agree on that, and probably Roshan is indicating whether the industry is pushing us to do more of the ramp and root. I think the root we have to do. I think probably we are overdoing some of the ramps, but if you see roots are there, you have to repair it. There is no doubt and no question on that.
Can I ask a question to all the panelists? Am
Yes,
I
yes.
wrong? Am I right in saying that if you can't repair a meniscus or identify a tear and properly deal with the meniscus, you are not supposed to do an ACL?
100%.
So we'll go for the next talk. Dr. Sridhar Gangavaram Sridhar is going to talk on all inside ACL repair.
Good afternoon, everyone. I'm Dr. Sridhar Gangavaram from Vishakhapatnam. First of all, I would like to thank the organizing team for giving me this opportunity. I'm going to talk about all inside meniscal repair. See the meniscal vascularity. The meniscus is divided into 3 zones depending on the 1/3 category. So outer 1/3 is a red zone, is highly vascular. Middle 1/3 is a red-white zone, which is moderately vascular, and the inner 1/3 is a white-white zone, which is completely avascular. So why you want to do a meniscal repair? Because it restores the function, contributes for the stability of the joint, has a chondroprotective action, maintains the load transmission, and minimizes the contact stresses across the knee joint. Also, the long-term results of the meniscectomy has proven that they cause degenerative arthritic changes. So the meniscus should be preserved whenever. Question comes, should every meniscus be repaired? No. Studies have shown that only 19 to 20% of the meniscal tears are repairable, and hence the appropriate and informed decision is required. So meniscal repair versus resection, you should have a scoring depending on
Hello? Hello, you guys? Any problem? Hello? Hello? Hello?
the location of the tear from the capsule, age of the patient, size of the tear, tissue quality, and also some qualifiers where the repair is indicated only if the score is less than 4 after considering the above. Connor has divided different classification patterns. It can be a parabic tear, horizontal flap tear, can be a vertical longitudinal tear, or complex tear, and most common bucket handled. Overall factors for successful meniscal repair depends on the location of the tear, whether it's in the red or white red zone, or a vertical or bucket handle tear, or if you're doing a concomitant ACL reconstruction because of the tunnel drilling, thereby getting good biology, very good successful repair. Traumatic tears under the age group of 40 years have a successful. Trying to avoid repair in chronic complex tears, in degenerative tears, in unstable knee where there is a high chances of 40% retear rate, and also in associated grade 4 osteochondral defects, you should avoid meniscal. Meniscal repair have rapidly evolved in the past few years because of devices and technical improvements. They need an intact meniscal rim required for anchor, and because of the ease of use and reduced surgical time and reduced neurovascular risk, gain much popularity. Meniscal repair techniques among the 3, still the inside-out suture repair holds gold standard method. How do you approach the meniscal tear? It's like a fracture fixation. So consider the tear as a non-union. So spend enough time in preparation of the tear, and also use enhancement techniques like debridement.
Hello?
Accessory portals to gain improved access and fixation configuration. So the devices should be placed perpendicular to the meniscal surface with a spacing of around 5 mm between the devices. Also, you should avoid stuffing of the meniscus and grab the circumferential fiber bundle to ensure optimal purchase strength. And implants should not be kept proud, and the rehabilitation protocol is individualized depending on whether you're doing isolated meniscal repair or concomitant ACL reconstruction. The all-inside repair devices first generation described by Morgan in 1991, they used curved suture hooks through the posterior portals to pass across the tear. They have high chances of neurovascular structures. The second generation devices, they're least invasive, they're suture based, they used ultra braided sutures, and 2-point fixation was allowed, thereby getting compression across that. They have a very high learning curve, they are costly, and they lack long-term results. So the third generation devices were developed with bioabsorbable materials. Most common are the meniscal arrows, and then screws, darts, and staples. They are composed of rigid polyl lactic acid material. Arrows were widely used, still carry the complications like cystic formation, transient synovitis, device failure or migration, inflammatory reaction, and chondral damage. This has led to the development of fourth generation devices where they are flexible, low profile, suture based with chances of getting variable compression and retensioning with least chondral damage. Still, there are contraindications for the all-inside repair. The meniscocapsular separations and anterior tears should be avoided with all-inside technique. The all-inside repair has become much popular because there is no need of posterior incisions or any assistant with least chances of complications, thereby saving increased operating time. All-inside devices, they come with many options like contemporary designs, extracapsular pleat versus all suture materials. They have active deployment method or a depth limiting mechanism. In spite of these advantages, they do carry some of the disadvantages like device misfire or breakage, greater difficulty in tight compartment where you may need to do pike resting of the damage, and they need an increased cost, and sometimes during the lateral repair have the chances of neurovascular complications. One concern regarding the all-inside sutures or the delayed tears that can be due to high strength of the sutures, damage from the large bore needles, and sometimes there is a tendency to over-tense the suture. And also, studies have shown that there are new tears propagating from the device insertion sites. Long-term results were not sure if all inside results were similar or compared equal to the inside-out repair. Take-home message: successful meniscal repair requires comprehensive armamentarium. You should be aware of inside out, outside in, and all inside, all the three repair techniques. And one should not be hesitant to know the role of each. And you have to do what's best for the meniscus and the patient, and not the easiest method. This is a video showing the longitudinal tear of the meniscus, where the tear is assessed initially, and then the margins are debrided for better biology, and then the all-inside device going into the peripheral rim, another bite of the inner rim. Once the device slowly retracted back, the sutures are slowly tensed, getting reduction at the side, thereby holding the menisci. If the meniscus is lifted up, one suture should go from the inferior surface, thereby the meniscus falls back into its normal anatomical position. So once again, we assess the tear, and then once satisfied with the reduction, completes the meniscal repair. This is another video showing the bucket handle meniscal tear, and especially in the bucket handle tear, we should spend enough time in understanding the tear and the rotation of the flap. And once the tear is reduced well into its position, we should first to the peripheral rim and across the. Once the device is retracted back, again you have to maintain the tension on the sutures, and also you can adjust the retensioning of the sutures. So same thing is carried again back at different place, and once you are satisfied with the repair pattern, that completes our meniscal repair. So this is how the video shows initial meniscal tear and completed arthroscopic repair of the bucket. Thank you all forever.
Thank you, Sridhar. The next talk will be Dr. Shivakumar from Guntur. He's going to talk on the parameniscal cyst.
Hi, good evening everyone. First of all, I would like to thank the organizers of OasisCon 2020 for giving me this opportunity to speak on this platform about parameniscal cysts. There are many cysts around the knee, including intra-articular and extra-articular, among which parameniscal cyst is relatively uncommon. By definition, the meniscal cyst is a cyst that is close to periphery of the meniscus and is always associated with a meniscal lesion. Incidence varies from 1.8 to 20% among various studies. Few studies show that medial cysts are more common than the lateral cysts, while other studies showed lateral cysts are more common. Two theories were proposed for the formation of the cyst. One theory suggests that synovial cells are displaced into the meniscus and produce a mucin-like substance there, leading to formation of the mucoid degeneration and cyst formation. The other well-established theory suggests that cyst formation occurs due to extrusion of the synovial fluid through the torn meniscal tissue. Phillips et al. Studied a series of 105 lateral meniscal cysts retrospectively and reported a prevalence of grade 3 meniscal tears in almost 99% of the cases. The predominant type is the horizontal tear with a cleavage. Other tears like radial tears can also present in meniscal cysts. A critical size of 12 mm of the meniscal lesion has been considered for the formation of the parameniscal cysts. Meniscal cysts are classified into intrameniscal cysts and parameniscal cysts. If the cyst causes only enlargement of the periphery of the meniscus, it is called intrameniscal cyst. If the cyst extrudes into the parameniscal tissue, then it is called parameniscal cyst. Medial cysts are predominantly arises from the posterior horn of the medial meniscus. Hence, they are usually palpable on the posterior aspect of the medial joint line, but they are less superficial than the lateral meniscal cysts. There is a connective tissue between the meniscus and the medial collateral ligament. So, the cyst formation occurs in this connective tissue initially and then later extrudes either anterior or posterior to the medial collateral ligament. Whereas the lateral meniscal cyst predominantly arises at the mid portion of the meniscus and they are readily palpable just either anterior or posterior to the lateral collateral ligament. Most of the time, the lateral meniscal cysts are easily palpable because they are very superficial and subcutaneous. They are usually palpable just anterior and proximal to the fibular head. The most common symptom with which the patient presents is the pain. The other meniscal symptoms like locking and giving way are usually less common in the meniscal cyst. The predominant clinical sign is tenderness at the joint line upon the loading. Sometimes we can see fullness at the joint line, but not always. Pisani describes that The cyst is more prominent when the knee is extended and becomes less prominent or even disappears when the knee is flexed to 45 degrees of the angle. Routine radiographs should include both antero-posterior weight-bearing and lateral views. Most of the radiographs are normal in meniscal cyst, but sometimes we can see an erosion at the tibial plateau or femoral condyle due to the increased pressure from the cyst. The definitive diagnosis of the meniscal cyst is based on the MRI. MRI is useful in location of the cyst and is also useful to define the meniscal tear and other intra-articular pathologies. It is also useful to differentiate the meniscal cyst from other cysts around the knee joint. Here is the coronal image showing a lateral meniscal cyst associated with the cleavage tear in the lateral meniscus. Here is the coronal section showing the medial meniscal cyst posteriorly, and there is a tear in the posterior horn of the medial meniscus. If MRI is contraindicated in patients like those having the pacemakers, then ultrasound, high resolution ultrasound and CT arthrography can be done. High resolution ultrasound is both highly sensitive and specific in diagnosing the meniscal cyst, and it is also a cheap technique, not costlier. Treatment aspects include both conservative and surgical. For any asymptomatic patient, there is no treatment required. Conservative treatment like percutaneous aspiration of the cyst with ultrasound guidance and injection of the steroid is indicated in those patients who are contraindicated for the surgery. Ultrasound guided aspiration can remove the fluid from the cyst, but the tract remains intact, so it may lead to recurrence. Injection of the steroid can induce the inflammation within the cyst, leading to fibrosis and closure of the cavity. Both the techniques are associated with high recurrence rate. The definitive treatment is surgical resection or repair of the meniscal tear and complete removal or debridement of the cyst. Initially, a diagnostic arthroscopy should be performed to define the meniscal tear. In almost 99% of the cases, meniscal cysts are associated with horizontal cleavage tear with a superior leaf and an inferior leaf. A needle should be passed from the cyst into the meniscus to establish the track. Once the track is established, pass the meniscal punch into this track and divide the loculations within the cyst and decompress the cyst. The cystic fluid can be decompressed into the joint cavity. After decompression of the cyst, introduce the shaver and remove the entire wall of the cyst and all the loculations of the cyst. This will aid not only in complete decompression of the cyst, but also this induces the inflammation in the cyst and leading to scarring and closure of the cyst. After complete evacuation of the cyst, we can either resect the inferior leaf of the horizontal cleavage tear of the meniscus, that is partial meniscectomy, or it is always better to preserve the meniscus by doing the meniscal repair of the horizontal tear. For closure of the meniscal tear, better to use a knee scorpion and a fiber wire. When is the open excision of the cyst indicated? If on diagnostic arthroscopy, if there is no meniscal tear found, then it is better to evacuate or excise the cyst from the outer aspect by giving an incision. Or if the cysts are very large and multilobulated, it is always difficult to completely debride the cyst from within the joint. So in those cases also, open excision is indicated. After diagnostic arthroscopy, make a incision over the cyst and excise the cyst completely. After removal of the cyst, close the peripheral edge of the meniscus to the capsule with the interrupted sutures. Either open or arthroscopic excision gives the good to excellent results in almost 90% of the cases. 77% can return to the sports to their previous level. Even with complete excision, 5 to 10% of the recurrence rate can be expected, which may require revision arthroscopy and excision. Among 38% of the patients, those who underwent partial meniscectomy, OA changes are seen after 10 years. So, utmost importance should be given to preserve the meniscus by suturing the cleavage tear. The take-home message is MRI should be done in all the symptomatic cases to locate the cyst and to define the meniscal tear. Cyst should be decompressed thoroughly either by arthroscopic means or by open means to prevent the recurrence of the cyst. And finally, meniscal tissue should be preserved in all the cases as far as possible to prevent future arthritis. Thank you very much.
So before going for the Subramanian talk, we'll have the Subair Khan's talk. He's going to share. TV guys, please allow him to share. Dr. Subair Khan is going to talk on the PCL avulsion. Subair Khan?
Yeah, I'm
Yeah.
sure now, sir.
Yeah, go ahead.
You're able to see?
Yes.
So the first step is to put the medial portal, post-medial portal. Well, the camera has been passed from the anterolateral portal. So we can visualize the post-medial compartment. After visualizing, we retain with the switching stick. Now we make a posterolateral compartment while the camera is from the anteromedial portal. First, initially we pass the needle, then the knife. So we make it very closer to the condyle so that we can avoid the neurovascular structure on the lateral aspect. Then we retain a switching stick. We'll try to push from here into the septum. Now the shaver comes from the anterolateral portal, and we can start shaving the septum. And still the switching stick pushes the septum. After that, the shaver switch to the posteromedial portal, and we can remove the septum completely. So by this, we make the transeptal portal. Once we make the transeptal portal, we can visualize the PCL levels bone fragment and release the soft tissue around the bone fragment. You can see the soft tissue is getting released. Once the soft tissues are released, we can see the assessment of the bone. So we should assess this bone to see whether it is reducible or not. So now you can see the reduction is possible. We pass a 2 fiber wire between the ACL and PCL around the stump, and it is pulled outside into the posteromedial compartment, the visualization of the posterolateral portal. And another limb of the suture comes around the PCL. And we take both the limbs into the PL portal. Now, PM portal, sorry. So now with the help of the node pusher, multiple half hitches are made. And we make sure that it doesn't strangulate the PCL stump. So we make it looser, and 8 to 9 multiple half hitches are made. So this is the first step before reducing the bone plug. So once it is done with the help of the PCL jig, reduce the bone, And you can see it is stabilized with the jig. The first step is the passage of the guide wire. So this guide wire comes through the hole in the jig, and we retain the jig and we over-ream with the 2.8 reamer by holding the tip of the guide wire so that it doesn't progress. So after passing the 2.8 reamer, nitinol loop is passed into that and it is pulled out from the posteromedial portal. You can see that the nitinol loop is pulled out in the posteromedial portal. Now you can see the blue suture. This blue suture is the fiber wire which is around the PCL stump, and this is the ethibond is the going to shift our buttonless tight rope. You can see the passage of the buttonless tight rope into the tunnel which we have made. So there will be two sutures. One is this ethibond, one is this fiber wire and the tight rope. Now the button is fixed to the tight rope. You can see with the help of the artery forceps, we push and we keep it over the bone plug. We don't pull it straight away. So once this is reduced, another button is connected to the distal end of the buttonless tight rope, the ABS button. Now once we reduce this, so both the ends of the button tightens up the tight rope and it is fixed. So now once the reduction is achieved, the fiber wire which is coming around the PCL is also tightened on the tibial end over the button. So that is the hybrid fixation in this technique. So we did around 28 isolated PCL avulsion cases for almost 5 years to 6 months follow-up between 2014 and 19. Mostly male patients. Most common injury was the road traffic accident. And 9 patients had an associated meniscal injuries. 4 patients had a medial meniscus root repair we did along with the PCL avulsion fixation. Whereas 2 patients had a medial meniscus repair and 3 had a partial medial meniscectomies. 26 patients had a very good result. There are 2 patients in the early days we had a laxity, but we managed without revising them. To conclude, open, the only problem is the prone position and associated lesions, and the delayed rehabilitation is another issue. Arthroscopic technique, it is less invasive, good and reliable results can be achieved without neurological injury. In hybrid fixation, the main advantage, even there is multiple fragments, can be held with the help of the sutures. If necessary, not through the same tunnel, or we can have a 2 tunnel along with the button fixation. Thank you.
Thank you. Thank you very much, Zubair Khan. So the next talk is on MPFL reconstruction by Dr. Subramanian.
So good morning. This is Dr. K. Subramanian, and thank you very much for giving me this opportunity. I wish to thank the whole YSS organizing committee and also Dr. Jay Prasad and his team members for inviting me for this talk. And my talk is on about medial patellofemoral ligament. And medial patellofemoral ligament immediately rings that we are going to talk about patellar dislocation. Incidence of primary patellar dislocation is about 5.8 cases per 100,000 population. And peak incidence is around the adolescent group around the age of 15. Highest risk of acute dislocation recurrence age is around 10 to 17 years. Redislocation rate ranges from 20 to 55%. So such a variation in the recurrence of redislocation report. We all know that patella always dislocates laterally. But why this happens like that? Why it does not go medial at all? But if we see, patella is laterally off-balanced inherently. As it is governed by tension between medial and lateral structures, if we see the lateral structures are inherently 10% tighter than the medial side, and hence it gives a transient balance towards the lateral side. So when there is a damage to the structures in the lateral medial side, then it becomes even more off balance, and the tension to the lateral side becomes much more significantly increased, and so that lateral tilt of patella occurs. So now if you see this one, where you have lateral structures and medial structures, lateral structures constitute lateral retinaculum, lateral capsule, patellar tendon, and position of tibial tubercle, and medial structures form MPFL and VMO. Normally, the subtle lateral deforming force is counteracted by VMO muscle, which is a dynamic secondary stabilizer. But if VMO muscle is weak, then invariably they would put more pressure on the lateral patellofemoral joint, and also anterior knee pain is very common in those with vastus medialis obliquus deficiency. What is a bony risk factor for dislocation? Especially the tibial tubercle. The tibial tubercle position is very important. If it is positioned very laterally, or if there is extorsion of the tibia or externalization of tibia, then the vector towards lateral side is even more, and hence there is a tendency for the patella to dislocate laterally. And when dislocation occurs, MPFL invariably gets damaged because the MPFL ligament gets stretched out and gets ruptured, and it leads on to the more tension going towards the lateral side. And the next thing you look for in the bony anatomy is the trochlear depth. See the normal trochlea here, and in those who are having a deranged trochlear anatomy, which is like this is like a Dijor type C type of trochlea, where the trochlear anatomy totally distorted, and this gives rise to the another important factor which contributes to the patella instability. So femoral anteversion and trochlear anatomy, and also tibial tubercle anatomy and medial patellofemoral ligament and patella alta are the most important thing which dictates the patella stability. So in terms of medial patellofemoral ligament, this is a very important thing which restrains, this becomes a primary restraint to the patellofemoral instability, especially at 0 to 30 degree of flexion. It has got a tensile strength of about 208 Newton, and it runs in two layers. Second, layer 2 on medial aspect of the knee joint. Its origins between adductor tubercle and medial epicondyle, inserts on the superior to the two-third of patella, and average length is around 59.8 millimeter. So clinical assessment will reveal there is a high Q angle and positive apprehension test. Positive apprehension test is done by keeping the patient's knee in near full extension and try to push the patella laterally, and ask the patient to flex the knee, then they will feel like the knee is going to dislocate, the patella is going to dislocate. Same time, you can also do a relocation test whereby you try to push the patella back in place to its original place, and the patient can do the flexion without much discomfort. So most important thing that you need to do in terms of investigation is apart from X-ray, where you can see a merchant view or skyline view to see the patellar tilt. What you need to see in a CT scan is the tibial tubercle trochlear groove distance, which indicates how badly the tibial tubercle is placed lateral to the normal anatomy. So draw a line to take two axial cuts, one at the level of the tibial tubercle, another at the level of the trochlear groove. Superimpose both pictures and see how far the distance between the tibial tubercle and trochlear groove is. And normal distance is around about 14 to 15 mm. And if somebody has got anything more than 20 mm, then it means that they have significantly laterally placed tibial tubercle. Then they definitely need a bony procedure. And somebody having within 14 to 20 millimeter or 15 to 20 mm is on the borderline cases. So MRI is a must to do in all the patients, not only to just see the MPFL injury, but also see the osteochondral lesions of the patella facet, and also to identify any other injury that can be missed. So to keep patella in the center, what can be done? First is medial patellofemoral ligament reconstruction, or can we do MPFL plus TTO? I'm not going to talk about the trocheoplasty here because it's out of the subject for this particular given topic. Trocheoplasty is done in situations where trochlear anatomy is totally abnormal, like in at least in Dijos C and D, or in some cases be managed just with doing MPFL plus or minus TTO. So how I decide whether I just do MPFL or should I also add a TTO or tibial tubercle osteotomy? It depends on what is the TTTG distance is. If the TTTG distance within 14 to 20 mm, then I could just stick on to the MPFL only. But if it is more than 20 mm, then I should also go and do a tibial tubercle osteotomy to medialize the tibial tubercle. So what do we do in MPFL reconstruction? Objective is to reproduce that anatomy of the MPFL. As we know that the MPFL is not a single stand structure, it's a fan-shaped structure, and to do attachment should be very precisely, and rehabilitation appropriately will only give the successful outcome. So in order to reproduce a fan-shaped anatomy, what we always try to do is to make a two strand tendons, so that we'll have two strand attached to the patella side and one strand attached to the medial epicondyle side. That is a typical way of doing MPFL reconstruction, so that you will try to establish that fan-shaped structure of the medial patellofemoral ligament. So what we do in MPFL reconstruction, first is you have to do examination under anesthesia. By doing examination under anesthesia, you're trying to see whether how bad the patella is displaced laterally, how much it is off-center. So in this particular patient, you can see that as soon as you push the patella to the lateral, it gets dislocated. And once you push it in, it goes back to its original place. And then next step is to put arthroscope inside the knee joint and see the alignment of the patellofemoral joint. As you can see in this picture of this patient who has got a recurrent patellar dislocation, and once I put a scope in, you can see that patella is totally tilted towards laterally, and trochlea and patella are totally incongruent, which indicates that there is gross instability of the patella. So how I do the procedure is 3 centimeter incision for the gracilis graft. So the usual graft that is taken is for gracilis, and the 3 centimeter incision is the same technique like what you do for a conventional ACL reconstruction with hamstring graft. You make a 3 centimeter incision for the gracilis graft, and then your incision, apart from the arthroscopy portal, is 2 centimeter for the medial border of patella and 2 centimeter for the medial epicondyle of the femur. And where I make my tunnel is over the superior two-third of the patella. So what I do is over the patella, I divide it into five lines, so that you have four lines, so that you have 1/5 of the patella. I do it at the first and second 1/5 junction, and then third and fourth 1/5 junction, so that it will be established over the upper two-third of the patella. So you make pass a guide pin first, so that it passes through the upper two-third in first and second two guide pins, as you can see over here, and then ream over there with 4.5 drill bit, and then you can make either a transosseous tunnel, or you can make an anchor technique, or you can put a knotless anchors over there, depending on whichever is your preference. And the pros and cons of each technique, I will just briefly outline at the end of this talk. So for determining the femoral entry point, it should be just proximal and slightly posterior to the medial epicondyle, and is well determined by the Shortle's point, where you use the image in this way, take a true lateral view at the junction of Blumenstadt line and the posterior border of the femur, just above that. Then you should be able to see the Shortle point, and that's where you try to drill your femoral entry point. And once you have done that, you can actually see that you attach the two strands of the gracilis graft to the patella for the two borders, and then bring it through a mini invasive approach through the medial epicondyle incision, and you can try to attach over the medial epicondyle with the help of interference screw. So we are using two anchors over the patella and one interference screw over the medial epicondyle. This is the typical way I do. You can also do a transosseous tunnel, whereby you don't have to use any implant in the patella at all. So you can go from medial to lateral and come again from the lateral to medial and insert into the medial epicondyle. That's also another way of doing it. But really, if you see how the techniques are being done, there are several techniques that have been described in the literature about doing a MPFL reconstruction, and the techniques range from making drill hole in the bone, and also soft tissue techniques also. As you can see in this one, they have mentioned about making a bone fascia tunnel. So you can actually make a groove over the middle border of patella and try to pass the tendon through that groove, and then stitch the fascia over the groove, so that you'll have a fixation on the patella side, and then the epicondylar side will be exactly the same like as always been described. If you see various techniques, whatever has been described, most of the technique will have a common thing, which is the femoral attachment has always been uniform in most of the techniques. Only debate is about the patella attachment, patella side, where you try to do either a single tunnel or a two tunnel, or using anchor, or using knotless anchors. Okay, all these variation occurs in the patella side. These are all very accounts towards some incidents that occurs in the patella, which creates trouble to the patient. That's why the more the technique is dependent on the patella side variation rather than the femoral epicondylar side variation. Epicondylar side is usually can use both the Shortle's point, or even Shortle's point also has been very distinct in the way that you have to get the true lateral. If you don't get the true lateral correctly, then there can be error in the shuttle point also. So, but you have to combine both shuttle point as well as your clinical judgment way, so that you try to get to the most anatomic point as much as you can in the femoral side. As you can see here, the Chassagne technique where he uses the soft tissue over the patella and the soft tissue over the femur also and gets fixation. And patella tendon technique where you turn the patella tendon 90 degree and try to attach the medial epicondyle. And quadriceps tendon technique also there where you try to take the quadriceps off, half of the quadriceps out and put it in the medial epicondyle area. So, but functional outcome of whichever technique you is not shown to be greatly different as long as you are maintaining the attachment point precisely very good. So this one describes about MPFL reconstruction, recurrent patellar dislocation, especially the use of the suture anchors. And there are also outcome comparison between the medial patellofemoral ligament reconstruction using transosseous sutures versus suture anchors, and has shown to be that there's not much difference in the outcome. So what you need to get for proper outcome is to get your anatomical attachments in a precise way. That is the most important thing. But what is the downside of all these things is you can have complications in the form of there are so many reported in the literature, but by doing proper rehab, instability, stiffness, all can be avoided. If the proper technique is followed, instability can be very well avoided. Infection, anterior knee pain, neurovascular injury, especially the subvenous nerve injury, painful hardware, patellofemoral arthritis, all have been reported. But more of concern for all of us is patellar fracture, which we don't want to happen. But there are several papers have reported that patellar fracture can occur in any type of technique where you are making holes or making drill holes or making anchors through the patella. So no technique is exempt from having a patellar fracture. And there is a very good review article about patellar fracture where he says that there's about 78% incidence in transosseous tunnel. Some papers even quote up to 20% incidence. And also the suture anchors, which we have recently started using, that also has shown to cause fracture, but not to the same extent like transosseous tunnel. And only place where you can't have fracture is that where you are not at all making any drill holes in the patella. That's where you have the least incidence or almost zero incidence of patella. So one has to use judiciously to do the technique for MPFL reconstruction so that to avoid fracture. The fracture incidence is around 2% to up to about 20% reported in the literature in various group of patients. Is there a role for lateral leads or medial reefing? I don't think there is any role for lateral leads because it has not shown to give any additional stability for patella, and the recurrence rate has been high. We can combine with other procedure if you want, but as an isolated procedure, it has got no role. Take home message for MPFL is it's a primary restraint for patella stability, especially at first 30 degree of flexion. Isolated MPFL reconstruction is optimal for those with minimal extraction of tibia with TTTG distance less than 20 mm. Several techniques are described for MPFL reconstruction. Outcome depends on technical aspect, especially if the anatomical insertion points are well maintained. Complication of significance is always a patellar fracture, though the incidence is present in all techniques. The transosseous tunnel will have slightly higher incidence. So with this, I conclude my talk. I thank you again for all the IOCS committee members. Thank you.
Subramaniam, how do you modify this technique for when the epiphysis is not fused, femoral location, femoral location point? Subramaniam, can you unmute? Unmute yourself.
Are you talking about the pediatric age? Eh?
Yeah, epiphysis is not fused, then how do you do MPFL reconstruction?
For doing you are doing trans epiphyseal, where you try to avoid the physis. Is that what you are telling, isn't it? Yeah, that's what you're asking. Yeah.
Patient is around 16 years.
Yes, yeah. So normally about around 16-year-old, where they are in adolescent phase, I usually check the patient what their growth status is. Some of the 16-year-old almost look like an adult. Then you don't have to worry at all. You can just go ahead and do as a conventional, normal way of doing it. But in those who are really like where the physis is not fused, then I check through the image intensifier and try to pass your guide wire exactly parallel to the physis, but well away from the physis in the transepiphyseal area. You'll have to use X-ray and do it. That's the only way I do it.
Supra, I completely agree with that. Even if I do in adult, I always check in the serum because I am very, very critical. I have to be very critical on the femoral entry point.
Yes, yeah.
In the pediatric age group, do you change your fixation device on the femoral side because you are very near to the physis?
Exactly. Yeah. Very right. So you have to direct your drilling to little inferiorly, not towards superiorly. And we are very, very close. And the worst thing that can happen is if your reamer goes from medial to lateral, it can damage the face very badly. So you should try to do an inclination from superior to inferior when you're starting from the starting point will be same, but your inclination will be different.
Any questions from any faculty? Yeah, so we'll go for our next talk. Dr. Sresh Gajjar from Mumbai is going to talk on osteochondral injuries. Dr. Sresh.
Yeah, hi, good evening, everyone.
Hi.
Thank you. Thank you for the invitation. Good evening, everyone. I'm Dr. Shreyas Gajjar, working at Kokilaben Dhirubhai Ambani Hospital in Mumbai. And this talk is on osteochondral injury. Cartilage injuries in the knee are common and occur either in isolation or in combination with limb malalignment, meniscus, ligament, and bone deficiency. Its management is challenging as hyaline articular cartilage has a limited ability to regenerate in response to damage. And surgical treatment is dependent on the individual patient and lesion characteristics. So when there is an osteochondral injury, in the early stages of chondral injury, there are cellular and metabolic changes. Also, there is increased tissue hydration and disorganization of collagen, which allows easy transmission of impact loads to the damaged cartilage, which causes progression of partial to full thickness cartilage defects. Furthermore, if these full thickness injuries penetrate up to the subchondral bone, they will allow some regeneration of type 1 collagen, but this is unable to operate if the stress or the loads continue, leading to further cartilage degeneration and progression of osteoarthritis. Also, the presence of concomitant pathology like malalignment causes increased focal contact pressures in the knee. Partial and total meniscectomies also increase contract stresses in the affected joint, approximately 6.5% of volumetric loss of cartilage per year, thereby leading to osteoarthritis. Also, delay from ligamentous injury to repair is a prognostic factor in meniscal and osteochondral damage. And therefore, any of these concomitant pathologies must be addressed either prior or at the time of cartilage repair. And the sequence of addressing these include alignment first, thereafter stability, followed by meniscus, and cartilage comes last in the management algorithm. Patients with osteochondral injuries would present either with some sort of a traumatic episode or chronic repetitive overload. They would also have features of pain, swelling, stiffness, locking, or catching, either in combination or in isolation. And sometimes these are picked up incidentally on MRI or at the time of arthroscopy during, for example, a ligament type of procedure. When we look at imaging, the radiographs generally would not be very helpful in the acute setting, except of course when there is a loose body, as you can see here on these AP and lateral views. Importantly, MRI helps in determining the depth, size, location, and the involvement of the subchondral bone. And it is quite useful to help plan the type of cartilage repair procedure. Now, when we classify these osteochondral injuries, the outer bridge classification is well known and historical. And the understanding is that as you progress from grade 1 to grade 4, there is progressive cartilage damage. However, more recent, the ICRS or the International Cartilage Repair Society classification is more popular, and also it helps us in reviewing our results of research and publication. But once again, it highlights a progressive deterioration from grade 1 to grade 4, where grade 4 involves a foot thickness problem with exposed subchondral bone. Now, when we look to treat these lesions surgically, the most or the simplest treatment would be a debridement or chondroplasty, and this involves addressing a loose flap of cartilage that may cause a mechanical symptom or a fusion, and this is debrided back to stable edge, either using a shaver or a radiofrequency device with caution. The goal here is to alleviate any mechanical symptoms and irritation, thereby possibly preventing propagation of the lesion from any mechanical stress on the unstable flap. The pros are that it allows immediate weight bearing, is a shorter period of recovery, and is inexpensive. But importantly, the congruency of the articular surface is not restored with this type of procedure. And this method of treatment is generally helpful for incidental lesions identified at the time of, for example, an ACL reconstruction type of procedure. The second treatment is if one has an osteochondral fragment. And the advantage by going and fixing it is that it allows an anatomical restoration by the original cartilage type, hyaline. However, one needs to be aware of the possible complications of fixation device, namely prominence, and also subsequent removal if metal implants are used. When we look at identifying and addressing cartilage defects, this algorithm is very useful. And what it basically highlights is that one needs to divide the lesions into small, which is less than 2.5 square centimeters, medium, which is more than 2.5 to 5, and large lesions. And then it is subdivided on whether there is a chondral involvement or whether there is an osteochondral involvement. So in smaller lesions with just a chondral involvement, a microfracture, but more importantly in the present day, micro drilling is helpful. Whereas if it is an osteochondral lesion, then the Oates type of procedure is recommended. And when it comes to addressing medium to large size lesions, be it chondral or osteochondral, some form of cellular modality of cartilage repair needs to be used. Although allograft is also an option, but this is generally not available and therefore not in the armamentarium in our country. So let's look at the pros and cons of all these techniques. The bone marrow stimulation being the simplest and the most popular. It is quick, minimally invasive, has a shorter recovery time, but importantly, there is replacement by non-hyaline, which is fibrocartilage tissue. And if we look at, or we summarize the evidence on this particular treatment, it basically has shown good results in smaller lesions, but importantly, the outcomes become less favorable in the long term with deterioration at 5 to 7 years' time. And more importantly, in the present day, micro drilling using a low speed drill is recommended over microfracture because the damage to the subchondral bone and also the quality of regenerate is inferior if we do a microfracture versus a micro drilling. If you look at the osteochondral autograft transfer system or the Oates procedure, the advantage is that it's a one-stage procedure with a shorter recovery time. The limitation is that it is difficult to address larger defects. Also, it is challenging to replicate the contour of the condyles. And also, it is well known that multiple plugs equals compromised long-term function, especially because of the gaps which allow regeneration with fibro rather than hyaline cartilage. So if we summarize the evidence for the Oates procedure, this study from Norway showed that there is significantly better outcomes following this procedure in smaller types lesion in the medium to long term. And also the return to sports was higher in the Oates versus the microfracture group. So this tends to be an option of choice for the smaller lesions, importantly involving the osteochondral part. Now, when we come to the cellular therapies, the autologous chondrocyte implantation or the ACI is popular. The advantage is that it is an easy procedure. At least the first stage can be done arthroscopically, and maybe the second through an open procedure. Unfortunately, the limitations are that this is a two-stage procedure and therefore expensive, has to undergo regulatory process. Also, the biopsy is taken from the not weight-bearing region, and there are issues with cellular de-differentiation and senescence. So really, although it was popular up until now, it is now kind of losing its popularity and repute to newer techniques, which I'll just subsequently highlight. So if you look at the evidence of ACI, this paper, which won the John Insull Award a few years ago from Boston, showed that the survivorship was 71% at 10 years, and there was improved function in 75% of patients with symptomatic defects at 10 years after surgery. However, the limitation was that patients who had had prior marrow stimulation, as well as if there were very large defects, and if this procedure was used, then the risk of failure was higher. The more recent options are bone marrow aspirate concentrate, and the advantage is that it's easy to harvest, it's a single-step procedure, the anabolic effects of chondrocytes on growth factors and the anti-inflammatory effects are helpful, and also there is a possibility of an arthroscopic implantation. The certain concerns are that we have still not been able to determine the amount of aspirate required, nor whether or not we need a scaffold. Also, the influence of host condition, like an immunocompromised host with medical conditions, is not clear. But if you look at the evidence from these two papers, one from Poland and this one from Italy, it summarizes that really it is a good option for grade 3 and 4 medium-sized lesions, and it has really shown improvement at 5 years follow-up. And also, if the patient is older with a large size lesion or with multiple lesions, that does not affect the outcome, unlike seen with an Oates procedure. So really, the BMAC procedure is attractive with its advantages and being a single stage. However, off late, the new kid on the block is this technique, which is the particulated autologous mince cartilage, marketed as AutoCart. And what it involves is that we shave off the dead cartilage, but we store it in a specific reservoir, and then it is mixed with PRP to try and stimulate the dead cells. And also it has a fibrin glue. And as you can see in these arthroscopic images from my case, you can address really these big defects very nicely from the patient's own cartilage. And the advantage being that it's a one-step procedure. There is replacement by chondrocytes, which is very important, and cartilage matrix without cell culture and harvesting of normal cartilage, as would be seen with the ACI. And also, this can be done arthroscopically. The only limitation as of now is that because it is a newer technique, we don't know the long-term outcomes, and also currently we are not sure about the exact quantity we require depending on the size of the defects. So if we look at the available evidence on this option, this has shown satisfactory outcomes at 2 years follow-up with very good hyaline cartilage regeneration, around 90%. However, longer-term follow-up and larger cohorts are required to determine its long-term benefit. So in summary, when we treat osteochondral injuries, it is important to remember that cartilage has a unique structure and function within the human body, and therefore its management following an injury remains challenging. The treatment should be directed dependent on individual patient characteristics and lesion location, size, and depth. And most importantly, the presence of concurrent pathologies must be addressed either in conjunction or prior to doing the cartilage procedure. And although research in this area is progressing, successful long-term treatments of one specific modality of cartilage repair is still awaited. Thank you very much for your attention.
Thanks, Reyes.
Thank you.
What are the ideal cases for particulators? Means ideal during which surgery procedures you like to do this?
So
Combined procedures.
yeah, so up until now, I was doing BMAC for medium to large defects, but currently the AutoCart option or the particulated chips option is quite handy because you don't have to go to the iliac crest. You can directly just whatever you're shaving off to stabilize the margins of the lesion, you can just store it and mix it with PRP and use the glue to do that. So I think any lesions which I am now seeing which are medium to large size, and I prefer to do a single stage procedure, I go for this AutoCart procedure.
So, thank you very much, all the faculty. And the wonderful talks was given. K. Subramanian, Dr. Shivakumar, Dr. Gangavaram Sridhar, and Subair Khan. Thank you very much. We'll wind up this session. Thank you. Good night.
Thank you to the organizers for the invitation. Thank you.
Thank you very much.
So much.